Good afternoon and welcome back. I hope you were able to have a break and maybe grab some lunch. We have a really exciting presentation ahead that I'm honored to facilitate. I'm Dr. Adrian Carmack. I'm a pediatrician in the Bangor area where I've practiced for over 15 years at Penobscot Community Health Center. I now only practice there 1 day a week as I have been working for the past 2.5 years as the medical director for the Office of Child and Family Services. I continue to care for children at our practice in the Bangor area and know how difficult it can be to help connect families to services for children. One, when we're not really sure what their diagnosis is, and then we're not really familiar with the services that are available. And how could we better serve our families, especially those who are affected by youth who have fetal alcohol syndrome or have been exposed to alcohol prenatally. So I have the privilege this afternoon to share with you some information about resources and learning collaboratives that are happening that can help providers to improve the outcomes for children and families who are affected by fetal alcohol syndrome, and how we can work together to help prevent exposure to alcohol prenatally. Our first speaker is from Minnesota, and she works for an organization called Proof Alliance. Proof Alliance works to bring awareness, research, and services to the field of caring for people with FASD and leaders in the prevention work. Marissa has over 17 years of experience working in the field of FASD. Marissa Lang is the Senior Program Manager at Proof Alliance. She began her career screening adjudicated youth for an FASD through a federal grant project at Hennepin County Juvenile Corrections in Minnesota, followed by working at Proof Alliance for 15 years. In her current role, she is responsible for the development and implementation of statewide youth and family programs. She is passionate about empowering youth and providing families and professional skills to support individuals with FASD. So it's my honor to introduce Marissa Lang, our speaker from Proof Alliance. Thank you, Marissa.
Thank you, Adrienne, and it's great to be here sharing resources with so many people. I'm going to try to share my screen. Let me see if I can do this. There we go. Okay.
Perfect.
So that was such a great, I don't even have to introduce myself. You gave so much information. But yes, I'm a Senior Program Manager at Proof Alliance. So Proof Alliance is a statewide nonprofit in Minnesota with a national reach. So we worked for over 20 years to prevent prenatal alcohol exposure and then support individuals with fetal alcohol spectrum disorders and their families. So we provide education and support to individuals and their families. We're funded by the Minnesota Department of Health, in addition to some foundation funding. And so what does Proof Alliance mean? It's kind of a goofy name, I'm going to tell you. So proof means, that we're grounded in research. We have the proof that prenatal alcohol exposure is the leading cause of brain injury in children. So we have proof that it's entirely preventable, and people living with an FASD can reach their full potential with the right supports in place. And I'm going to talk about some of those supports that can be provided. Alliance, we could not accomplish our mission without all the partnerships we've created, both in the state and nationally. We partner with public policymakers and lawmakers to get the work done and do the system change that we need to happen. And so I want to just kind of, you have probably seen the statistic, but I share it because the number is astounding, really. So research shows as many as 1 in 20 children in the US potentially have an FASD. And this was a study done in 4 regions of first graders. And this is actually a pretty conservative estimate. And so, I think what's most astounding is people don't talk about FASD a lot, even though it's more prevalent than autism, it's more prevalent than Down syndrome. And so I want to talk a little bit about how we're supporting individuals with an FASD and their families and how we can collaborate with other people here. And you could reach out to us if you're interested in some of the programs. So I'm going to kind of give you a whirlwind tour of Proof Alliance programming. starting with screening and diagnosis. So we have an FASD diagnostic clinic in St. Paul in Minnesota. And then we also partner with a lot of different clinics and community-based agencies to develop capacity for diagnostics assessments and screenings. And then we facilitate a diagnostic consortium of all the Minnesota clinics that are providing assessment. So in our next kind of programmatic area is professional education. So this is our training department. This is where our work never ends. And so last year we trained, I think, 4,100 Minnesotans, and that included teachers, high school and college students, healthcare professionals, social service workers, judges, law enforcement, crisis teams. We have some new collaborations with some county crisis teams. And we offer customized training based on the audience, and we meet them where they are with their knowledge base of FASD. Currently, we're offering something called ProofCon Pro, which is a virtual quarterly virtual conference, essentially. And it's starting the end of October. And there's different topics. And so the October topic is going to be FASD and mental health. And the presenters include national leaders in the field of FASD. And all this information you'll be able to find on our website after. Next, I'm going to jump into the area that's most near and dear to my heart, is our youth and family support. So we're one of the only FASD focused organizations nationally with comprehensive and really robust youth programming. And our youth programming includes support and support groups with a golden retriever that comes. And we also offer that support group virtually, and we have a lot of youth from other states joining us. Skills groups, social and recreational groups. And the social and recreational groups, you know, it may look like it's light and just for fun, but it really is intentional, because we know that a lot of times these youth can feel isolated, and they might not have the skills to develop healthy peer relationships. So it's sort of a facilitated activity to help them develop some healthy friendships. We offer educational series for youth, which are also available virtually. So currently we're doing one called Let's Talk About My FASD. That's a really empowering series for young people to learn what their diagnosis means. You'd be surprised how many teens I work with that have this diagnosis and really have no idea what it means or how it might impact their life. And additionally, other educational series related to healthy sexuality, boundaries, self-advocacy, substance use prevention, anything that might kind of intersect with FASD in young people's lives. And then our parent and caregiver programming includes virtual and support, in-person and virtual support groups, retreats, educational opportunities, so that parents and caregivers who maybe have a newly diagnosed child or maybe foster parents can learn about FASD and then learn some effective parenting strategies. The next area of our work is our chemical health and recovery work. So as part of this work is our virtual and in-person support groups for bio moms of children with an FASD. Also includes in-person retreats. If anyone wants to come to Minnesota, the retreats are 3 days. They're a blast. It's really about kind of shedding that stigma and shame that comes along with being a bio mom of a child with an FASD. And then also related to our chemical health and recovery work, we partner with women's treatment centers across the state, and we provide long-term recovery support grants to those agencies to sort of increase their capacity to work with women who may be pregnant or parenting children with an FASD. And then it's also a really effective prevention strategy as well, you know, because the information is offered to all women that might be at that location. Another area is our prevention and public awareness programming. That's probably our most fun programming, just because it's flashy and it's fun. We've been really fortunate over the years to create some partnerships with creative teams that have done some things pro bono for us, including billboards, TV, social media campaigns, rebranding, different things like that. So if anyone's interested in learning how we've developed those partnerships with creative teams, we can let you know. Our first public awareness and prevention campaign was done by pro bono by a creative team with Target Corporation. So it's been really cool to foster those relationships over the years. Also in our prevention and public awareness work, we partner with colleges and have a program called our College Ambassador Program. So that's providing small grants to colleges, and the students take on the initiative of public awareness and prevention on campus. So we're swimming upstream for people that may become pregnant later on down the line to provide that prevention information. Another section of my work personally and our work at Proof Alliance is our advocacy and public policy work. So this is grassroots advocacy. It's meeting with legislators. We have had some really landmark legislation over the years, and we've also partnered with other states so they could maybe replicate some of the work that we've been able to do. So we've had a law requiring annual FASD training for foster care providers. That's a newer piece of legislation that passed. Since that, we've trained over 500 child welfare social workers in nearly 70 counties in Minnesota. We work to pass a law that requires all children entering foster care to be screened for prenatal alcohol exposure, because we know that in foster care, children are 17 times more likely to have an FASD. So, we're trying to kind of build this environment around these children so that their people that are caring for them understand their diagnosis and can help with some effective strategies. And then we worked on a law allowing prenatal care providers an exemption to report alcohol use by pregnant individuals to child protection. So this one there was a lot of dialogue. I mean, there was a lot of kind of views on both sides with this, but the goal was to establish trusting relationships so that when a woman comes in, she feels comfortable to disclose that she is using alcohol, and she can get a referral if she has an alcohol use disorder or substance use disorder, rather than the fear of having her children taken away. So we felt that that was really important. And then some of our national initiatives, we have a pilot partnership with Proof Alliance North Carolina. So North Carolina, it's an initiative through the ARC of North Carolina. And this effort between Proof Alliance and the ARC North Carolina is to expand programming to support planned and alcohol-free pregnancies. So it has a prevention focus, but this is a pilot because we've had other agencies kind of reach out to us and want to work closely with us, and we're happy to do that. And so we're just kind of learning what that partnership would look like through this Proof Alliance North Carolina. And then we work closely with FASD United, if you're familiar with them. So they're sort of the national umbrella organization related to FASD, and so there's a bunch of state affiliates with FASD United, and Proof Alliance was the first affiliate of FASD United, which was formerly called NOFAS. You might have heard of NOFAS. And then another national initiative is Our Children Are Sacred app, and it's an app. And so we know that FASD is an issue across the nation, but we recognize the impact that it's often more devastating to communities of Black, Indigenous, people of color, given historical trauma, systemic racism in healthcare. And so in a cooperation with an agency called CAT Marketing and the Casey Family Foundation, Indian Child Welfare Program, we created an app guided by a co-creation team to provide FASD educational information using various communication outlets and platforms, reaching tribes in Minnesota and beyond. So that's available to anyone. It's a free app, and there's just a wealth of information on there. And then another national collaboration, and you're going to hear from the Safest Choice team next. So the Safest Choice, the Learning Collaborative, aims to reduce incidence of prenatal alcohol exposure, improve outcomes of children. And that this is a program partnership between Proof Alliance and the Boston Medical Center. You're going to hear from them. And it uses an extension of community healthcare outcomes, which they could probably speak to much more clearly than me, for virtual education to engage healthcare teams and community health centers. So that is a whirlwind of just sort of an overview of Proof Alliance programming. I'm going to move on here. These are just some graphics. As you can see, you know, the Fresh Start Forum, that's that group I was talking about. That's a virtual support group for bio moms of children with an FASD. That's our logo for Our Children Are Sacred app. This is just kind of a flyer so you can get a picture of what a series like Let's Talk About My FASD for Youth looks like. And then you can find all of this on our website. And a good place to look for kind of upcoming events, or if you're looking to refer families for any virtual events, is you can go to the website, go to our events calendar, find virtual groups there. There's also a lot of great information you can download. There's FASD strategy guides related to at school, at home, a variety of different things like that, and fact sheets and new prevalence data. We like to put a lot of research on our website as well. You can also find it's called an Is It FASD checklist, which isn't an official screening tool for an FASD, but it's more to get people talking, to get people starting to think about, well, could this potentially be an FASD? And then once you kind of go through this Is It FASD checklist, then there's information about what would be the next steps for an FASD evaluation. So I'm going to stop sharing there. And I'm going to let the Safest Choice team jump in.
Thank you so much, Marissa. I think Denise will be sharing our slides.
Thank you so much, Marissa. I already downloaded the app, which looks amazing. So I learned so much. Thank you for your presentation and for the great work that's happening in Minnesota. But what's so exciting is that the work that Proof Alliance is doing in Minnesota is spreading beyond the borders of Minnesota, and that they're partnering throughout the Midwest. And lucky for us in New England, they've partnered with Boston Medical Center to bring the Safest Choice, which is a program using the ECHO model, which Jackie and Nicole are going to tell us a little more about. So I first want to introduce our next two speakers. So we have Jackie German, and Jackie has a master's degree in public health and epidemiology. She's the director of the FASD educational programs at Boston Medical Center and Boston University School of Medicine. She has managed several FASD and expert research and educational programs for interdisciplinary teams funded by the NIH, SAMHSA, the CDC, and HRSA. Together with Jackie, we have Nicole Kitten, who is a project coordinator for substance use related educational programs at Boston Medical Center. For the past year, she has worked with the Safest Choice Learning Collaborative to support FASD education and prevention across New England and the upper Midwest. Nicole earned her master's in public health from Boston University in community health programming, with a particular focus and interest in maternal and child health. So thank you both, Jackie and Nicole, for being here today to tell us about this great program.
Thank you so much, Adrienne. I'm Jackie, and I'm going to be starting the presentation, and then Nicole will take it over. So thank you for that really nice intro. So we're here to talk about the Safest Choice Learning Collaborative, which is a 3-year HRSA-funded program which delivers education to providers across the country about prenatal alcohol exposure and fetal alcohol spectrum disorders. Can we go to the next slide, please? Thank you. So we don't have any disclosures today. We can go to the next slide. So I just wanted to talk a little bit about the Safest Choice team. This program is funded to Boston Medical Center. However, it is truly a collaboration between Boston Medical Center and Proof Alliance, which you already heard about from Marissa, and Boston University Schools of Medicine and Public Health. So we couldn't do it without any of these folks on the program. Next slide, please. So I was asked just to talk a little bit about fetal alcohol spectrum disorders, because while they're quite prevalent, they are underappreciated and not fully understood by many medical providers. And there's a lot of misinformation about prenatal alcohol exposure. So FASDs are a range of conditions attributable to prenatal alcohol exposure that include behavioral, learning, and physical problems. So alcohol is a teratogen, which adversely affects normal brain development throughout all gestational ages. FASDs are permanent and the most common preventable developmental disability in the US. I was going to mention the study that Marissa also mentioned in JAMA that came out in 2018, where it was estimated that up to 5% of first grade children have an FASD. So slide 5, the next slide, please. Thank you. There are several diagnoses that fall under the umbrella of FASDs. So there's fetal alcohol syndrome, which is the most extreme version, and that includes facial features. So these are really just the tip of the iceberg, meaning they're the thing that you can see, but really represent the smallest percentage of overall cases. So the majority of cases are in the category of the other diagnoses, and these are mostly invisible disabilities, as they're mostly learning and neurobehavioral. And those include partial FAS, alcohol-related neurodevelopmental disorder, and neurobehavioral disorder associated with PAE. Thank you. So there are many consequences of prenatal alcohol exposure. So there are the physical manifestations, which are facial features and low birth weight and growth and birth defects and organ problems and damage to the brain. And that leads to behavioral and intellectual disabilities, which really lead to lifelong challenges in many different areas, ranging from school to mental health and substance use issues to employment and sometimes legal problems. So, you know, this is how things can play out, and it doesn't mean that they always play out this way. And the more supports people have on board, the better that they do. So moving on to the next slide, please. So I'm going to give you a little bit of an overview of the Safest Choice program, and Nicole, my colleague, will go into a little more detail. So we have two different tracks. One is the pediatric clinic track, and the other is the prenatal track. We are currently in our second cohort. Our first cohort was last year from April 2021 to May 2022. And we're right now halfway through cohort 2. Each cohort has 22 clinics enrolled between the prenatal track and the pediatric track. So the way it works is that each track meets one time a month for 75 minutes. And in terms of our curriculum, we start off the whole program with an hour-long webinar, which is sort of meant to bring everyone up to speed in terms of the fundamentals of FASDs. And after that, we kick off our 10-session Project Echo sessions. So we use a format called Project Echo, which I'm sure many of you know, but in this format, we meet over Zoom once a month, and in each session, we have a learning module for about 10 minutes where we present on a topic, and then we have time for questions, and then we move on to a case study presented by one of the health centers. And we have rich discussion around the cases and offer recommendations. We've also added, demonstration videos, interviews with individuals with lived experience, breakout groups, and other tools to help enhance the learning experience. Part of Project Echo is that the motto is like all teach, all learn. So the learners learn from each other, the facilitators learn from them, and it's sort of like a learning circle, essentially. We offer free CME, CNE, and social work credit for participation. And we also offer something called technical assistance, which Nicole will go into in a little more detail. So next slide, please. So this is a map of our cohort 1. As you can see, we have enrolled clinics from the upper Midwest and New England. The yellow dots represent the pediatric clinics, and the orange dots represent the prenatal clinics. And then the sort of shadow outline represents the Native American health centers. We have rural, urban, and Native health centers enrolled. In this cohort 1, we had one health center from Maine, St. Croix Regional, who participated in both tracks. Slide 9, please. This is the map of the current cohort. As you can see, we were able to enroll more health centers from Maine in this newer cohort. This was with the help of Madonna Mooney from FASD Maine. She really facilitated our contacts and connected us with many of the participants. And so we were able to enroll Midcoast Hospital, Passamoquody, and Edmond Irvin Pediatric Center. So again, we have a really nice spread across New England and the upper Midwest, and a mix of, different types of clinics. So Nicole is going to take over from here. Next slide, please.
Thanks, Jackie. So as Jackie mentioned, I'm going to give a little bit more detail on some parts of our echo sessions. So this is an overview of our curriculum and the topics that we cover throughout the year for both the prenatal and pediatric tracks. So there are a few topics that are covered in both tracks. As you can see on the top, there's an overall introduction to FASDs, stigma and bias, screening for prenatal alcohol exposure, community resources, and legal and documentation issues. But although they overlap for both cohorts, we do tailor the information to each type of echo. And as you can see below, there are several topics that are specific to each track, with prenatal topics that focus more on reducing prenatal alcohol exposure by teaching the prenatal healthcare teams how to screen for and counsel patients about the risks of alcohol use during pregnancy. And the pediatric topics on the bottom right are more geared toward training pediatric healthcare teams on how to identify and care for children and adolescents with suspected or diagnosed FASDs. Next slide, please. And in each session following the clinical content portion, we have a patient case that's presented by a participating health center. And here is just some of the common themes that have come out of those presentations and discussions so far. Some examples are addressing misleading information about prenatal alcohol use by health professionals, friends, and others, and coping with the guilt of alcohol use prior to confirming pregnancy, navigating fear of child protective services, and other themes as well. And overall, participants have found these case discussions to be a helpful part of the sessions, not only for learning how others have approached similar situations, but also for feeling like they're not alone in the challenges that they face in their practice. Next slide, please. So in addition to our echo sessions and our core curriculum, we also offer additional personalized training to participating health centers who want it. One thing we do is halfway through the program, we check in with all of our health centers to see how things are going for them so far and just try to tailor our program to their needs as much as possible. And then throughout the year, we offer additional training sessions based on the group's interests. So for example, we've offered some extra sessions on motivational interviewing and diagnosing an FASD. And then beyond that, if individual health centers are interested in tailored support for their clinics, we can offer a broad range of support in skills-based training, systems change, and patient and community engagement. So these are just some more examples of ways that we can provide some support. Next slide, please. And this is just a snapshot of who is participating in the program. So this is from cohort 1, but we see similar numbers for cohort 2. And as you can see, we've seen the highest enrollment among physicians, nurse practitioners, nurses, but the program is open to anyone who's part of the healthcare team. So we've had a wide array of roles participate, and participants mainly come from pediatrics, obstetrics, and family practice. Next slide, please. And so this is a HRSA-funded program, as Jackie said, and with most programs, there is an evaluation component. And so for ours, we do this in the form of surveys that we survey participants at different points of time, once before the program, once halfway through, and then again at the end of the program. And some of the outcome measures that we're looking for and looking at are participants' knowledge in prenatal alcohol exposure and FASDs, participants' self-efficacy in screening, counseling, managing, and referring patients with alcohol use, PAE, or potential FASDs. We're also asking about practice change, if there's been changes such as using appropriate screening and intervention methods for PAE and alcohol use. So we do have some preliminary data from cohort 1, but we are still compiling and analyzing. But so far, we've been seeing some positive trends in these measures. And there was a quote from one cohort 1 participant who said that after completing Safest Choice, I am a better physician and my patients receive better prenatal care. So there's been some promising feedback so far. Next slide, please. And then finally, I just wanted to share a little bit more of the preliminary data we have from our midpoint survey of the cohort 1 participants. Regarding the program, 97% of respondents agreed that they were learning from their peers. 94% found the training format engaging, and 93% felt the program facilitated new collaborations within each health center. And there's another quote from a cohort 1 participant that I just wanted to share real quickly. It says, "Safest Choice has been very impactful for our health center. I recommend it for other practices. Alcohol use and pregnancy is pervasive, and Safest Choice empowered me to promote positive changes in my pregnant patients. Safest Choice went beyond the epidemiology and taught me various skills to effectively engage with my patients surrounding the theme of prenatal alcohol use." So I just wanted to end on that. And on the next slide, you'll see our contact information and our current web page. And we are also in the process of launching a new website. So that will be coming soon. Thank you very much.
Thank you very much, Nicole and Jackie. That was wonderful. Many of us have participated in an ECHO, but for those who aren't familiar with ECHO, it's an acronym for, I had written it down in case, Extension for Community Healthcare Outcomes. And it's a great new platform for education that is used a lot in the medical field, but also across other fields as well. And it involves, as Nicole and Jackie said, where there's information that's presented like in a didactic, and then there's case presentations and time for discussion. And it's been a great way to help continue our education. It was started in New Mexico, where they needed to sort of spread the information about hepatitis C and the treatment for that. So there's many Project ECHOs available. So we now have a few of the providers from the centers that participated in the first cohort. We have Janice Small, and Janice is from the St. Croix Regional Family Health Center in Princeton, Maine. So if Janice and Andrea and Deb are able to turn their cameras on. So Andrea Tracy is a pediatrician. She works at the Irvin Center, which is part of Maine General. And then Deb Hagler is also a pediatrician, and she is part of Mid-Coast Pediatrics. And so we were going to ask each of the practitioners who participated in the Learning Collaborative a few questions and get some of their feedback on how it went. So I think we heard a little bit about how Safest Choice was introduced, but maybe Janice, since it sounds like you were in the first cohort, how did you learn about Safest Choice and how was it introduced to you?
Madonna Mooney. She had ties with our director here and she reached out for the program, and then it kind of trickled down to me.
Great. And for those who are present, Madonna Mooney is part of FASD Maine and has been a strong advocate for families and children affected by FASD. Dr. Tracy, how did you learn about the program?
Hi, everyone. I think my first memory is listening to Doug Waite give a talk at the Maine AAP conference a couple of years ago. And at that point, I had this aha moment like, oh, my knowledge is basically, if you look at that iceberg diagram earlier, and I trained at Boston University for my PEDS residency, and I knew about the tip of the iceberg, and all of a sudden I realized I have a lot to learn pretty quickly about the rest of the iceberg. Particularly because I had switched from doing primary care to seeing foster children in foster care for their comprehensive evaluations. So I knew I was getting funneled a high percentage of cases that we were likely missing. So at that point, Madonna Mooney contacted me and made me aware of some other resources, including Proof Alliance. I started tapping my local resource of Ann Euchre, the neuropsychologist at Edmund Irvin Pediatric Center, and listened to a really great presentation by Susan Hemingway, and thought, oh, I missed the boat. I missed cohort 1 for Safest Choice, but then found out there was a cohort 2, and I was I think one of the early ones to sign up.
Great. And Deb, Dr. Hagler?
I think I heard about it through multiple channels and was fortunate to hear through some patient advocates as well. And I think when a patient asks you to do something, at first I thought long and hard, I'm so overextended that I'm not sure I have space in this. But when you hear from patient advocates to consider, you think twice. And then I think I heard Madonna give a talk about how prevalent it was, and I thought, oh, I'm sure I'm missing this and I need to do more. So that's how it landed.
Great. And if we can go back to Janice, what were some of the challenges that you were experiencing when you're caring for families and that led you to commit to the training?
Kind of like the other providers had noted, I don't think I knew how much I was missing until we got some more of that information, like the pieces that really kind of pull that together. Also being as rural as we are, sometimes it's nice to know those techniques and get everything kind of started and moving and interventions early as you can with what you can, while you're getting everything else in order. So that part of it was fantastic.
Wonderful. Andrea, do you have anything more about the challenges that you were experiencing before or other reasons why you wanted to commit to the training?
Yeah, so kind of coupling that the knowledge that the population I'm seeing now, the infants, children, and adolescents who are in foster care or kinship care, have a high rate of substance exposure, and recognizing that it was pretty well documented for opiates, pretty well documented for tobacco and even marijuana, but not as well documented for alcohol in the birth records that I was reviewing. So one challenge was, how do I figure this out without having access to the birth parents when I evaluate the child with their kinship or foster parents? So that's been, it continues to be a big challenge, but this training has prompted me to kind of use as many avenues as possible. Conversations with kinship parents, looking at records more thoroughly. And then we do a multidisciplinary evaluation. So the psychologist will sometimes have the chance to talk with the birth parent, and the psychologist will do that part of the screening directly with the birth parent. So we do have our challenges, but through Safest Choice, we've kind of learned ways to address our screening.
Learn some screening tools and ways to document it, I would say. Would you say it's been helpful with that?
Yeah, I think, one thing that I've recently realized is that we need to be documenting our screening results, whether they're positive, negative, or inconclusive, and always have a part of our record include that screening, because then passing it on to the primary care provider, if it's inconclusive, there may be another visit in the future where a provider might be able to complete that screening. So 100% screening, I think, is what we're shooting for.
Yes. Deb Hagler, did you have any other challenges or reasons that caused you to decide to commit to this? I know you mentioned some that already.
I think that I think also just raising awareness, and I should go back and say Andrea Tracy did a great job in her role as the head of the foster care committee for our AAP chapter in discussing this in that forum. And the more we can start talking about this and educating people, again, because the prevalence is so high and it's so relatively under the radar, then the more we can support families, women, children, to get appropriate training in place to help people that can support families. So there's evidence-based treatments that are available that we don't have yet in Maine, and that requires some of our colleagues in the behavioral health community to do additional training. And the more we can talk about this, the more we can educate. We have wonderful advocates in FASD Maine that are getting their physician colleagues and prodding us. And so with that, I think we can also rise up and help advocate more to our colleagues to educate ourselves and do a better job for our patients.
Right, because the more that we as the providers understand what's available for our youth, then they will have improved outcomes in their family life, in their life in the community, and their life at school and at work. So it's so important that we as providers understand what we should be connecting our families to. So this has been so much great information. So how do you think things that you've learned through Safest Choice, like what can you share with us about education that you've gotten that you can, how do you think it will impact the families that you're serving? You want to start with Janice, since she went first. She completed the cohort first.
I think in some respects, it's helping me be comfortable enough to ask those questions and how to ask them in a appropriate manner that is, not as offensive, or, how to have those conversations that make it easier to have that I don't know how to word that. Basically, communication improvement and how I put that across and how it's received, I guess, from our patient population. And then provide the support that we find. It was a great opportunity to have access to a lot of, well-educated individuals that I wouldn't have had access to before, and updated information about it, as at my fingertips as far as their apps and things of that nature. So I think it's just kind of given me an overall better view and comfort with that conversation, and then therefore I can help people a little bit better, I guess.
And being a family nurse practitioner, I would imagine you're caring for the moms and the
Yes.
children and the parents. So you're really caring for the whole family and want to have that conversation and want them to continue to come to your service, correct?
Yes, yes.
Yeah. Communication is really key. Dr. Tracy?
Yeah, I think the safest choice has been really valuable. They also have this Padlet, which I'm not sure if was mentioned, but we have access to a kind of a website type of thing for more resources. And I realized that, you know, this whole tip of the iceberg thing, there are resources everywhere. I mean, just at this conference, realizing that Proof Alliance has this great website with so many more things to access. And I mean, what we have in Maine, I want to just put in a plug for FASD Maine's website. If you haven't gone there, go to that website. It's tremendous. It's well organized. It's kept current. It's user friendly. There are these resources, news updates, and I mean, I can get lost in that site. There's a lot, lot to learn there. So I think the other thing that I want to just say that I really value about doing this Echo Learning Collaborative is that even though it's Zoom, I have a bunch of colleagues that I work with at the Irvin Pediatric Center who are learning the same information. So I have pediatricians, a couple of child psychologists, a neuropsychologist, psychologists, an occupational and physical therapist. And now we all have this foundation for improving patient care for those that come through this pediatric center, where we really do most of our work is multidisciplinary evaluations of children with neurodevelopmental behavioral challenges.
Great, thank you. And you mentioned the FASD Maine, and then I think it was Marissa that mentioned also the FASD United, correct? So there's several resources now that we've got for folks that are really wonderful. So we'll have, Deb, did you want to talk about any of what you think the education has helped you through the Learning Collaborative? And then we can open up for our other speakers if they had any other thoughts.
Well, there's a couple of things that I just wanted to, and I apologize if there's some background noise, but one is a huge thought about prevention, because it is a preventable diagnosis. And again, the language around that and how we talk about that, and how we talk about that with our patients, and starting both with parents and with youngsters in our adolescent population. So that really, really hit home with me. And then Dr. Cobble, who's a pediatric and adolescent psychiatrist who is part of our team from Midcoast, really in a robust discussion last session about what do we do with different diagnosis and how do we think about that when we make a diagnosis, helped me think about it in really a different way, and thinking about that the alcohol exposure is an etiology, and then there's a lot of language or nosology around the diagnosis. And that made me think about, if we can have that in our head, all children who have an FASD will have an alcohol exposure, but not all children who are exposed to alcohol will have an FASD. But if I know about the exposure, just like I know about a patient with elevated blood glucose levels or a diagnosis of diabetes, say, whether it's type 1 or type 2, I know to screen them for eye disease, kidney disease, neuropathy. If I know about that alcohol exposure, I can start to really, depending on the earlier I know, the better, to start to follow them and intervene really early and monitor them for a whole host of different things. So it really sort of reframed that idea of early diagnosis, early prevention, following really closely to intervene, and that just, I don't know, that really, just as a provider, that really hit home for me as somebody that starts with kids early. And maybe that just is, I'm thick-headed and I needed that translation, but it really helped me sort of frame things to help my patients in a new way. And again, I love all the language and the discussion we have, and I take pieces of everybody's ideas and the group ideas and write down little words and notebooks to try with patients. It's like tinkering, with your craft. So I very much appreciate that, and I'll stop.
Thank you. That was wonderful. So I had a little extra question about what does everyone hope for sort of in the future for youth with FASD and families, maybe things that we don't have yet here in Maine or even in Minnesota or Boston, what you look forward to happening. I know for us here, how helping us to diagnose would really be helpful. I don't know what each of you, we can, Marissa, since you were our first speaker, if you want, you look like you're nodding.
Absolutely. I mean, I think increased diagnostic capacity is huge. I mean, I think it's, and then everything else sort of can unfold after that. And so that's an ongoing challenge for us in Minnesota, and I know nationally too, is just increasing that diagnostic capacity. And then finding appropriate interventions that can be replicated. I think there's some things that work. There's been some great outcomes that we've had in some of our groups. But I think it's putting some of those practices into some research-based information on interventions for youth with an FASD.
Anyone else?
I'm just going to jump in on the prevention arm again. I think I forgot to say, one of the biggest things that I have taken away too is that close to 50% of pregnancies are unplanned. And if we can really do a better job with education around prevention, and I think in the era after Dobbs, I'll just say it, we really need to work hard on prevention for young people and have them understand the importance of prevention in these circumstances.
So the group here can't see all the chat, so I'm going to read what one of the comments was, sort of to second what you're saying, Deb, is that the more we can do to encourage healthy and low or no risk alcohol use all the time, the more we lower the chance of a surprise pregnancy being alcohol exposed. Maine, and then also Maine needs resources to diagnose both children and adults.
I would also kind of like add a standardization across the state would be kind of nice, like how that screening moves from both that mother to the baby to your records. I'd like to see all of that move a little bit. That would be fantastic as part of.
Right.
Yeah.
And I think it would be interesting for us to find out about what you were saying in Minnesota about the screening that happens for all youth coming into foster care. Marissa, we'll follow up on that. Would be so important that we have that. Andrea, I think you were going to say something.
Yeah, I think I do have the hope that this is kind of just the beginning of the training up of the workforce of people who interact with mothers and infants and children. There are some other trainings available. Madonna Mooney made me aware, and many of you probably, of this Families Moving Forward, a training for interventions with behavior challenges for children with FASD. But that's an example, and there are others that takes resources, and that kind of goes back to what's happening with the federal and state government. But I do want to just mention the Fasd Respect Act, which it has been proposed and co-sponsored by all of the representatives in Maine. But I just want to make sure everyone kind of has that on their radar, because if that were to pass, then there would be more resources to work with for the training up of those of us who are doing this work.
Thank you for adding that. So say someone today listening wanted to get involved, what would they do if they wanted to? Is there another cohort happening, or Jackie or Nicole? What's the next step?
Yeah, so right now we were only funded for 3 years to do these first 2 cohorts. So we're actually looking for funding for a 3rd cohort. So we're hopeful that we get that, but right now it's not secured. So if we do get it, we would definitely, love to let people know. And obviously we would let Madonna know, and she could let other folks in Maine know.
Yeah, and we actually have lots of great ways to get that information out. So we can stay in touch.
Mhm.
The Maine AAP through Children's Behavioral, I'm with the Children's Behavioral Health. So we have ways to get that information out. So please keep us posted.
Okay.
But in the meantime, we've mentioned several resources, one being FASD United webpage, Proof Alliance, the safest choice information at Boston Medical Center, and then the app about our sacred children, which is wonderful. So also in the chat, we had several thank yous, but it doesn't look like there's a question. There's a parent, as the parent of a young adult with FASD, I want to thank all of the participants on this panel for their amazing work. You are truly making a difference. And then another comment was, as a sibling of a person who has had FAS, so grateful to these providers and the Safest Choice team. So thank you. Thank you all for what you're doing, and remember that you are making a difference. So this is really great. It's like the beginning of this exciting time here of work that we're doing, which I really appreciate all of your time. Did anyone have any other comments or thoughts they wanted to add? Well, thank you very much. And so there's still a little more to go today, and it's so important, our work, all of the work that we're doing to help our families and children here in Maine. So thank you all for being here, and thank you for this great conversation. Take care.
Thank you.
Thank you.
Hello, everybody. I'm very excited to welcome you to session 5, which is Trauma, Substance Use, Pregnancy and Parenting, Navigating Difficult Conversations. My name is Elaine O'Connor, and I am the Medical Director of the Maine Mom Program for the state and also for Maine Health, and also work as the Director of Perinatal Addiction Medicine at Maine Medical Center. And I'm absolutely thrilled to be here to talk about this incredibly important topic, really how to navigate difficult conversations when you're caring for this very vulnerable population, and then really how to provide self-care and as you recognize the impact that it has on you. And I'm really excited for Melissa's presentation, and we'll introduce that in a bit. But first, I wanted to just start a little bit with some of the challenges I've seen in the 15, 16 years that I've been providing care to pregnant patients with substance use disorder. And I think one thing that was really mentioned to me as we were starting to put together this session by Deborah was it's really important to remember that being trauma-informed, in other words, providing trauma-informed care, doesn't mean that the trauma goes away. So I think we think about, as we're caring for patients, that somehow if we're doing it in a very trauma-informed way, that they're not going to have the typical reactions one might have when they have experienced trauma. And that's not really fair to think that, but I think we do think of that sometimes as we're providing care. And I think sometimes it can be really confusing, the reactions people have. So I printed myself a list of all the different reactions that patients might display as a result of having experienced trauma in their life. And I've really liked when people have said, talking to patients about, not what's wrong with you, but, what happened to you, what have your experiences been in life? And I think, just mentioning a few of the ones that I encounter pretty regularly, just to sort of tee up the conversation. And I think one of the big ones is really irritability and hostility. And that one I think always seems a little surprising to people, but when people have experienced trauma and they're in that setting, particularly pregnant patients with substance use disorders, that it feels like an entirely out of control situation. situation. So they don't, nothing about what they're dealing with in the room when they're seeing you as a provider feels in their control. So oftentimes there's this kind of irritable and hostile potentially presentation that you have to navigate your way through. I think other times I find patients having a hard time making decisions. So it may be, and that can be a delayed cognitive reaction associated with experiencing trauma. So just trying to help your patient make decisions, but having it feel like a very overwhelming process for them. There's certainly a strong element, of course, of shame and grief, which we've talked about. And I think just sometimes hopelessness and despair. And also lack of trust. I mean, this is a patient population that probably has encountered the healthcare system and not had good experiences. So what us on the ground providing services shouldn't necessarily think that people walk in ready to trust us the second they come in our exam room. So just being aware of all those things that might be going on with your patient. I think one of the other things to think about is, when you have a patient that's really connected to care, but still struggling, that really can be associated with underlying trauma that they've experienced, that they may be continuing to engage in high-risk situations or behaviors, maybe having an increased use of alcohol and drugs as a means of coping with their trauma. So as we're on the ground, not necessarily interpreting it as not engaged in treatment, but rather as part of what's going on in their lives and ways in which we can support our patients experiencing that. And then I think another really important part of this conversation is really how do we care for ourselves? And that I think is one thing that I have really started to recognize over the years of providing this care, is that this really impacts us as providers on the ground. And I think it took some time for me to really realize that, but I'm now able to talk more openly, I think, about that. And I think one of the things that's challenging is that we have to really quickly adapt and move on. So what I mean by that is when you're sitting in an exam room with a patient, they may have been dealing with say they had their brother die of a drug overdose 2 days before, you're trying to be present with that patient, support that patient. But then you step outside the exam room, you might have, 2 minutes before you go into the next exam room. And I'm always really trying to be cognizant of not bringing that to my next patient. So presenting to my next patient in a way that, that's sort of a blank slate, so to speak. But I think in part, my sort of quick response to trying to process through that so quickly meant that I really didn't process a lot of it, because I was just sort of being like, oh, shut the door on that. And, not necessarily recognizing the impact that had on me over time. There's certainly a numbness that I think that can develop when you experience, the recurrent stories of trauma. I personally have felt somewhat disconnected from colleagues that are not engaged in this type of work. So if you're talking to a friend that works in banking or something, and they're talking about a difficult day they had, and you're sitting there thinking, well, I sat with a patient today who lost custody of their child forever. They had a termination of parental rights hearing, and they're never going to see their child again. Like it feels so different than what your friends or family might be experiencing, that sometimes I almost felt sort of alienated from conversations because of what we do is so different. And then I think one of the things that's been hardest for me is really the hopelessness and the helplessness sometimes that we feel, particularly when the system doesn't work. And I think of that, recent situation I have with a patient who's 35 weeks pregnant, who's really done very, very well in the last 3 or 4 months. She, went to residential. She's really, not using substances. She's really focused on her recovery. But because she's had such a long history of substance use disorder, that I think there's a lot of people in her life who are not able to kind of recognize that, and the system is not supporting her in the way that it should be, and with the recognition that people can change. And then as a provider, when you feel like you can't do anything for that patient because what they need is a safe home or supportive environment, and you can't sort of miraculously give that to the patient, and that at times, for me anyway, feels very hopeless and somewhat helpless. So that's just sort of an intro to the conversation that we're going to be having today. And before I introduce Melissa, I just want to encourage folks to put questions in the Q&A as normal, but we're going to hold off on answering them and doing the questions in the breakout sessions. And if you know you're not going to be able to attend the breakout sessions, please put your questions in there anyway, and we can respond after the conference. But we will be addressing questions during that breakout session. We really are looking forward to that, because that's going to be a time when we can really dive in deep to some of these issues. So it is my absolute pleasure to introduce Melissa Doyle, who's going to give our presentation here. Melissa's Master's of Social Work is the Resilience Strategy Director at the Maine Resilience Building Network. Melissa works to promote trauma-informed systems in communities across Maine through outreach, training, and capacity building. Additionally, Melissa helps advance Mervin's initiatives around youth mattering through education, technical assistance, and systems integrations. A clinical social worker, Melissa brings 15 years of experience in the trauma and healthcare fields. Her work has included direct service and administrative leadership around issues of interpersonal, sexual, and community violence. More recently, she has led training and implementation efforts that support trauma-informed care approaches, environments, and clinical practices. Additionally, she has extensive experience working with individuals and organizations in recognizing and addressing vicarious trauma and secondary traumatic stress, and building personal and organizational resilience. And I will say it's been an absolute pleasure to brainstorm this presentation, and I had the privilege of seeing her slides, which are awesome. So you are in very good hands, and you're going to have a great workshop. So Melissa, I will pass it to you.
Great, thank you. Thanks, Elaine. I'm just going to ask you to stay on for 1 second, Elaine, to make sure that you can see my slides, if you don't mind. Just so that. All right, hopefully you're seeing them. Are you can focus?
We are, yep.
Okay, great.
Perfect.
Well, thank you, everybody, and thanks, Elaine, for the sort of framework that you laid, getting us started, and also for the introduction. I appreciate that. So we're going to ground our conversation really in thinking about sort of trauma and what it is and its impacts, and then we'll think a little bit together too about how is it showing up for each of us, as Elaine mentioned. So I think you set that up perfectly for us. And Elaine gave sort of a great introduction of who I am and who Mervin is. I have nothing to disclose. So this is what we'll be thinking about for the next 45 or 50 minutes together. So before we get into the conversation, really around navigating challenging interactions or conversations, specifically in the breakout rooms in depth, we'll spend this time thinking about trauma, the foundation for understanding trauma, its impacts, opportunities for engagement and response, and then some time exploring impact on us as providers and practitioners when we're working with folks who have faced significant adversity in their lives. And I know that brain development and trauma impacts have been touched on in other sessions as well. So I hope there's still some new information in here for you all. And while we don't have the opportunity to go super in depth in all these areas, I really want you to, think about this and how to incorporate it into your work and practice, and how do we support survivors sort of as they navigate these systems and these environments as well. I also want to offer that anytime we're talking about trauma and impact, it can be really challenging for us. We all come with our own histories and our own experiences. So I just, encourage you all to do whatever you need to do to take care of yourself throughout our time together. So I want to start by thinking about the scope of trauma, that it's more than just the types of adversity that we may be used to thinking about, and give some frameworks for understanding that trauma impacts a little more holistically. What we can see in this chart is sort of the breadth of trauma experiences, events that result in sort of lasting effects on health and well-being, and how it can really happen at a variety of levels. So we can have individual trauma that we can think about happening more or less to a person outside of relationship or community. Could be a car crash, death of a family member, something like that. We have interpersonal trauma, which are events that occur in the context of relationships, domestic violence, sexual violence, child maltreatment, human trafficking. And then we have collective trauma, which are traumatic events or sets of circumstances that are shared by a group of people. That could be racism, homophobia, structural oppressions that we have. And although we may have sort of an intuitive sense about what trauma is or what makes something traumatic, I want to sort of share more specifically that it's really an event or series of events that's experienced as physically or emotionally harmful, where the effects are lasting. And that effects lasting piece is an important component, because while people can experience the same event at the same time and under the same set of circumstances, say in a bus crash, people will walk away with different effects. We can't make assumptions on impact based on just hearing sort of what happened to somebody. It really depends on so many sort of individual circumstances. Trauma can also be acute. It can be chronic. So acute, those one-time events. Chronic, it can happen over time, and complex, where we have intersecting traumatic experiences. And what we know is that really about 60 to 70% of Americans have experienced trauma probably closer to that 70%. So we know that it's pervasive and it affects the vast majority of the population in some way. But I also, anytime we're talking about trauma and its impacts, I also really want to make sure that we're acknowledging survivors' strength and resiliency, to honor the work that survivors are doing every day and the coping strategies that folks are developing. And Elaine, you touched on this, that sort of, it may look different than our coping strategies, but folks are engaging and coping the sort of the best way they can. And so I want to acknowledge sort of the strength that folks bring to the table as well. And I think that's a really important component to always sort of make sure we're marrying the conversation around resilience and risk. So I want to start by thinking about how trauma gets processed in our brains and looking at the structures that are impacted that give rise to some of the behaviors that Elaine mentioned and that we'll be talking a little bit about, and also the cognitions, the emotions, the physical effects of trauma as well. So I want to start with the prefrontal cortex, which is sort of up front. This is where we're living most of the time, ideally. It's our evaluative brain, and it evolves last in our brain development, and it's what really sets us apart from other animals. Our prefrontal cortex is the command center for functions that involve logic, evaluation, thinking. It's our learning brain, and it supports our emotion regulation and executive functioning. It's how we take in new information, integrate it, and then practice new skills. And so this is where we want to be living throughout most of our day. You know, we're evaluating and really practicing some of our, we're regulated essentially. When we confront a threat or a stressor, we switch from the prefrontal cortex being the driver to the amygdala being the driver. And the amygdala is a small little almond-shaped structure, part of the limbic system that resides right in the middle of our brain. And it acts like a fire alarm for our nervous system. So when we confront a stressor or a threat, the amygdala interprets that stressor. It kicks off the stress response system in our body, the stress cascade, where adrenaline and cortisol increase so that our heart rate goes up, our breath gets faster, our pupils dilate, our mouth dries out, we become hyper-focused. We can all kind of imagine that stress response. So the amygdala is now driving the bus, and we're in survival brain. And the only goal of our brain at that point is to protect our bodies and minds. So that's the brain that a lot of us may be experiencing when we have folks who present with maybe some irritability or some of those hostility, some of those coping mechanisms, right? It's that survival brain most likely that they're in. It's really focused on protecting itself given its history, all right? So in typical growth and development where there hasn't been a lot of diversity, these parts of our brain, the learning brain and the survival brain, the prefrontal and the limbic system and the amygdala, they're linked and they have communications so they can sort of switch on and move on and off and then move fluidly, efficiently evaluating situations. But when we experience prolonged activation of the stress response system, particularly earlier in our development, we get traumatic, chronic, toxic stress, which I think we've all heard about. And that can cause impact to our brain in two ways. So it can disrupt our typical brain development. And we know that our brains are developing well into early adulthood. So 25, 26, 27, and we still are developing the prefrontal cortex. So the actual architecture of our brain changes, and development of the prefrontal can be disrupted or delayed. And so a lot of those emotion regulation skills or those executive functioning skills may not be learned or maybe really impacted or delayed. And so when someone has an early history of trauma, so really before 25, 26, when I say early, they don't necessarily learn how to make the transition from calm to distress and back to calm again. And then toxic and traumatic stress also primes our brain to go into the stress response much more easily and quickly. So we enter that survival brain more easily. We're right there. We're sort of living right there. And because our brains are so experience dependent, when danger or even perceived danger is consistently part of our experience for a length of time, or if the brain or body feels like it's under threat, those neural pathways become stronger and we tap into that stress response, like I said, really easily and quickly. Also, for people who experience trauma, danger signals and signs can generalize, okay? So this means that signals in the environment that many of us most of the time would interpret as neutral, so say all men or certain smells or loud noises, they become generalized triggers for us. So even when the environment is sort of objectively safe, if we could step back and say, yeah, there's nothing here that's going to cause me danger, the brain is still generalizing certain triggers. So even though it appears safe, it really doesn't feel that way. So again, imagine folks entering our systems where there are new sights and new smells and all of those things happening around us, and these generalized danger signals in their brains. It can be a very dysregulating environment. So folks are sort of having more triggers in some way. I also want to note, just to sort of practice what I'm preaching, that survival brain can be incredibly adaptive, especially for kids and adults. It's what kept them safe, and especially for kids. And at some point it may become maladaptive or disrupt daily functioning, but we can understand that their brains are doing what it can do to keep them safe, that's its best way of knowing, right? That's what it's practiced in the past. And especially folks and kids who experienced, child maltreatment, the freeze response is a really powerful one, the shutdown one. There's such a power differential between adults and kids. And if they experienced maltreatment at the hands of an adult, that freeze response was the way they coped and adapted. And so when we see it show up later, it's really understandable, I think, that we can carry those responses from our early experiences into adulthood. And same with some of the other responses that we're seeing. They're learned behaviors that kept us safe. They were at one point at least adaptive. Okay, so we can begin to understand, I think, and have some compassion for, why is it showing up in front of us? So I want to think about how a typical stress response happens, and then where it becomes problematic, and how cumulative and toxic stress occurs. So if we look at the typical stress response, it's sort of like a bell curve, that we interpret a stressor, we have a phase of activation where our nervous system gets activated. Then we are at the height of the stress response, where cortisol and adrenaline are running through our bodies. And this is for both positive stress and then when we feel, and when we feel under threat. Cortisol and adrenaline, again, are running through our bodies. It's helping us keep hyper-focused on what should be in front of us, what we need to do. And it's the amygdala really driving the response. So we're reactive, right? We don't process a lot in this. We're just sort of doing. And then we're responding to that threat. And then typically what we want to see is to come over the bell curve where we have, when the threat is passed, we see an opportunity for release. And release could be something physical, laughter, crying. It could be something a creative expression if it's sort of a positive stress response. And then our parasympathetic nervous system kicks in, and that acts like the sprinkler system to the fire, so to speak, so that we can reach this phase of exhaustion and then rest and recovery. So that's what typically we should see. And this is an adaptive response that evolved over time. And I like to explain it by saying, like, imagine a lion out on the savannah where it sees a gazelle that it wants to eat. And it goes through the same sort of bell curve experience of, it has a period of activation where it might see that gazelle, and then it gets in that heightened response where its blinders are on and it's just going to race across, get the gazelle. It's going to go through a physical release, eat the gazelle, and then it's going to fall asleep and then have a period of rest and recovery until it's ready for its next sort of time to eat or threat. The period between activation and exhaustion for that lion can happen within a matter of minutes because there's so much energy that goes into this, but they have a real release that allows for the exhaustion and the total depletion and metabolization of stress. That's what our bodies are designed to do, to have this complete stress response from start to finish. And that is what very often does not happen. Both sort of for us as providers, and I'll talk about that later, but also when folks are experiencing trauma, again, or maltreatment, our stress response becomes problematic in sort of three ways. When there's an increase in frequency between events, so that when stressful events are happening in a really rapid fashion, so a child who is experiencing abuse with regularity, for instance, the body doesn't have time to go through that whole stress response. So there's not enough time. The frequency is increased. Or an increase in duration of when a kid, say, has to be activated and scanning the environment to be on alert. And that could be, say, in a home where there's where there's untreated mental illness or there's a lot of dysfunction occurring. It's sort of they're living at a threat level consistently. So there's an increase in duration. Or there's a disrupted rest and release cycle and repair cycle. So when the environment doesn't support completing the stress cycle, and again, we'll talk more about this later in terms of our own impact, but we sort of get partway out of the stress response, but we never complete it. We never have that full rest and recovery. And that, I think, again, is what Elaine was sort of speaking to. You never get this moment of full discharge or full metabolization. So we can understand the impact of trauma and stress on brain development that really primes our brain and bodies to activate in the sort of face of real or perceived threats. And we can understand a little bit more, I think, why patients or clients are showing up sort of with a lot of different reactions that we'll think about next. So thinking about that brain science, I want to think a little bit more specifically about some presentations, engagement strategies, and then trauma inquiry. So Elaine again named some of the things that she sees in her practice, and those are certainly consistent with what I saw when I was practicing as well with folks who experienced trauma. And we'll offer opportunities to think about why that may be, in addition to what Elaine's already named. But trauma really can present differently for different people. There's no one way that survivors do or should respond. And looking at a list, it's sort of like, am I supposed to memorize all of this? And no, but what I hope folks get out of that is that just as there's diversity in traumatic experiences and the effects, there's diversity in reaction, right? And presentation. And the goal is just to be aware that not only will there be a variety of presentations, but different areas of our functioning can be impacted in dynamic ways. So things can shift with time and relationships, access to healing and treatment, more or less support, which again can be challenging if folks have come in with a narrative that's surrounding them, right? That they are something, they are their addiction, or they are a bad parent or a good parent. We have labels that we carry. And so it can be hard for survivors to begin to trust that they can shift. And at times what they'll gain or lose if they shift too. But what we can bring with our interactions with survivors to our interactions with survivors is that sense of curiosity when we see emotions or behaviors or physical reactions that may indicate they're not at baseline. So we can understand some of the brain science behind it now, but there's no checklist that directly correlates, right, from an experience to a behavior or an emotion. So we want to offer patients and survivors the opportunity to tell us what they need versus assuming that we know, right? We can be curious about things, but be curious with them and then offer them the opportunity to sort of share experiences with us. And we have to remember that agency has really been taken away from most survivors. And so our interactions can also offer the opportunity to value their knowledge and lived experience. And so that we can bring, again, this awareness of this range of presentations, but to really put them as sort of in the driver's seat to let us know. And we'll talk more about that with trauma inquiry. So we can think about, again, this is just to sort of expand our thinking a little bit. The impact can be cognitive and confusing what's safe and dangerous. Maybe somebody had, when folks are experiencing maltreatment as little kids, especially, it can be confusing to know who to run towards, who to run away from, what's safe and what's dangerous. So there can be that real cognitive sort of disruption or loss of trust in self. And remember, when folks get better, sometimes that they lose certain supports, right? They may lose some housing supports. They may lose a case manager. And so getting better at times can feel risky to some folks because they lose some things that maybe they already had. Emotionally, we can see some presentations around, some typical things like nightmares, sleep disturbances, hypervigilance. But we can also see it as a difficulty trusting others. And sometimes we see that active activity, that active irritability and hostility. And then other times we see folks enter a shutdown response, feel chronically numb or empty. Behaviorally, we might see some behaviors around provocative behaviors or withdrawal, isolation, startle reactions, or easily alarmed. And then physically, there can be some reactions as well to trauma. So I just want to sort of think holistically as we're, working with folks that there's again, no one way, but folks really need to sort of define sort of impact for themselves. And we can be curious with them when we see certain behaviors or emotions or cognitions. And so thinking about that approach, I want to think about opportunities to reframe behaviors that we might be seeing, to understand a little bit more about what actually might be happening versus what we sort of assume we're seeing. So I've worked in healthcare for a long time, and I can say that some of these descriptions that are ones that I've seen written very plainly in notes. And I believe that the providers weren't intending disrespect necessarily. They were capturing what they experienced as certain types of behaviors. But these weren't inviting collaboration and openness either. And so it didn't actually allow us to understand what's really beneath some of these things that we're seeing. So we know that language matters, what we call people, how we talk about people, and our lens of viewing those behaviors also matter. So when challenging behaviors arise, it's not about excusing what we see as sort of, maybe we see some behavior that we might have formerly said is manipulative. It's not about challenging it and sort of moving on, but it is about engaging with or being curious what's really underlying some of those behaviors. Okay, so it's not about excusing them. They may be maladaptive or not appropriate to the setting. So we can work on modeling new behaviors or adapting our responses, but we can understand these as trauma responses now instead of just sort of an attempt to frustrate us or cause us problems. And then, because once we can engage with what the foundational issue is, then I think we can make some shifts and movements and be a little more productive. So lots of times, yeah, we see folks who might appear unmotivated, or they, they're not seeking treatment, they're not taking our treatment recommendations, for instance. But we can understand maybe that comes from being overwhelmed. Maybe that comes from being a little bit frozen. Maybe that again comes from this fear of loss of services, or someone who's manipulative. That's another one I think we've seen for, as we've heard that description before. But those folks can also have been getting their needs met in these ways, and it's worked in the past, and doing whatever sort of is necessary to survive. Attention-seeking behavior. Maybe it's someone feeling sort of disconnected and alone, unheard, and it's sort of not an appropriate way to look for connection, but it's a way that the sort of they've learned over time works in some way. So again, we're not going to excuse them, but we can start to engage with what's really going on versus sort of writing them off and just moving on. Okay, so we can get at those foundational issues and causes a little bit better. In thinking about engagement in general, I think our humanity and our authenticity and our curiosity are really the critical tools that we bring. There are some great trauma-informed and evidence-based models of practice out there, but the best treatment model isn't going to work if we don't think of ourselves as the providers, as the peer supporters, really in any role as part of the intervention itself. So how we approach and implement models of care is as important as the model itself. And so I think a strengths-based approach, which I think is sort of what should be infused in all our models of care, it really can be as simple as reframing an assessment question or adding just a question or two to an assessment to get at strengths and what's going well, even on a small level. So in demonstrations I've seen where this is done, it really adds maybe a minute or two to the whole interview or the whole assessment. And it can really be as simple as even asking a parent what their child did well this week or something that the client accomplished, okay? And even when we're sitting with a lot of feelings of hopelessness and distress ourselves, if there is some place that and it's not about just sort of singing sunshine and rainbows or promoting that, it's about really foundationally, what is someone also doing well, as opposed to what's only the deficits that they're coming in with. So it's asking them for these little moments, maybe they don't have to be huge accomplishments, but something that they maybe did a little bit better this week than the week before, or where we see some strengths, and it allows to this different conversation and this different lens for them. So we're balancing deficits with resilience and strengths, and that offers opportunity for not only better initial engagement, but sustained engagement and collaboration, so that we have fewer instances where folks drop out of service altogether. So we're really promoting wholeness, not just sort of what's the presentation or the presenting issue. None of us ever want to be seen as sort of the sum of our worst moments, but sometimes that's what clinical interviews end up eliciting is just sort of this list of problems, and it's built into our medical records, right? We have a problems list, but we don't sort of validate strengths or what people are doing well in that moment, even if it's not solving everything. Just where are they bringing capacity themselves? We also have to think about our relationship with sort of the choices people make. I think that choices will look different to everyone, and we have to be okay enough. And I'm not saying we have to be okay totally, but okay enough. Maybe not totally comfortable with giving people the option to choose a path that's different than what we would have chosen or what we would want a loved one to choose, and what, we want the best for them, but it may be a different path than sort of what we would choose. And I can think of when I was working in the hospital setting, and this came up around restraining orders all the time, that providers wanted someone to go get a restraining order if there was domestic violence, right? And oftentimes they would say, just go do that. That's going to keep you safe. And what the client would or patient would come back with is not necessarily that maybe some past involvement with criminal justice system. They had a poor experience. They feared for where their information was going to go. It might have actually amped up the situation, elevated the risk for them. And so we had to be okay with those decisions and honor sort of that lived experience that they had, that they actually knew their situation better than we did. And so while we felt comfortable saying, this is the best option, in reality, it maybe wasn't for them. Or even if it still was, we had to be okay with their choices, that agency that they were bringing. Okay. So okay enough is where I ask people to live. And then I want to think about environment a little bit too, and that paying attention, if we're seeing, again, clients or patients in the office, we can have to be aware that these can be overwhelming spaces for them. If we're seeing people in their homes, we can understand that folks may have different feelings about us being there. So offering choice whenever possible is an indicator, I think, of respect. It's providing an opportunity to give agency back to the patient, and decreasing sort of the power differential that we know sort of what this environment is, and I'm going to dictate to you where to go and how it's going to look. Simply asking something like, do you want the door open or closed while we do this? So not making that assumption that everyone will want the door closed because because their information won't be heard. But in fact, for some people that make them feel like they're trapped and they can't get out. So asking really simple questions when we can, and acknowledging that the environment itself can be sort of a challenging place to live, I think allows, again, some agency back for the client or patients. And then I would say the number one thing I hear from trauma survivors is just to ask before doing. So ask before touching them, ask before immediately going into, a new area, a new topic area, or going, asking questions that might be sensitive in nature. Just ask if they're ready to move on, if it's okay if I sort of do this part of the exam, those sorts of things. That's sort of the number one thing that I've heard over and over, is just please ask, or please let me know what's coming next. Okay. So those are some overall engagement strategies and thoughts that I have. And then it's always how do I find out more information that will help me actually deliver this care? If I don't know what's happening, how am I going to sort of be aware of sort of trauma and be trauma informed? How am I going to do that if I don't know? And so providers often feel uncomfortable, I think, with trauma inquiry outside of a screening or an assessment, which is really understandable. Screenings and assessments give us a structured way to ask questions. And we often feel as if we don't have the training or the knowledge to respond to a disclosure if we get it, or we don't want to offend patients or re-traumatize them. And those are really understandable reactions. I just want to start with that. But by starting with broad inquiry or trauma inquiry, it allows for that strengths-based perspective to be utilized and can actually work to alleviate some of those fears. So I'm going to go into the questions in just a second. And then assessment and screening can be warranted if it's indicated, but we begin the relationship with sort of a conversation of strengths and sort of what's happening today for you. And so we can understand a little bit about the impact of experiences on that patient or that client. So yes, what happened to you versus what's wrong with you. But what do you need today is sort of the next evolution of that question. What can I do today to help you? And then because screenings tend to focus on events, and inquiry shifts to support and sort of what folks need in this moment. It allows for that greater understanding of the impact of events, not the events themselves. We really don't need to know what happened. We need to know how it affected somebody. And so disclosure is not the goal. What the goal is really to create a safe environment for patients to share as much or as little as they choose. It minimizes the need to retell stories over and over, which in fact can be re-traumatizing. And again, it balances that trauma narrative with the resiliency narrative as well. So these are the questions that sort of broadly I use, and then of course they have to sort of be put into your own language and your own style. But these questions, are there any life experiences that would be helpful for me to know about? Do you have any preferences that you'd like to share with me today to make you feel comfortable? These allow the patients themselves to determine what they feel comfortable sharing with the provider, avoid prompting the patient to have to recount details of the event, because oftentimes patients often come in, feeling like, well, the doctor asked me, or the clinician asked me, or the service worker asked me, so I need to tell them. And that sets up a really challenging dynamic. But it also allows us to validate the impact of those experiences on their health and well-being. And again, if the patient, what they're saying suggests current danger, we can absolutely proceed with a risk and safety assessment or refer as appropriate. We can do an intervention, again, if that's warranted. But this sets up a different sort of dynamic that we're inviting their lived experience and their knowledge to sort of take center stage, I think, and then we can get to sort of, well, what would be most helpful in this moment? So they're designed, again, to assess current need versus simply asking what happened, because that's not actually going to give us a ton of information. So it allows us to focus on current functioning today. Inevitably, there'll be times that the patient and clients do become dysregulated. We're not looking to necessarily avoid this completely, because I don't think we can. There'll be times of activation. There'll be times that folks have had experiences earlier in the day that they're bringing with us in with them to the situation. So there'll be times of dysregulation. It's inevitable. So the key is sort of to have tools. How do we work through some of this as best we can? And the first course of action is always going to be to regulate ourselves. Often we sort of become reactive to situations. When we see someone else enter their stress response, we mirror that energy, and our own nervous system kind of ramps up. So we begin to enter our own stress response. So we need to make sure we're aware of what that looks like for us and our brains and bodies, and then regulate those first. And I'll give some opportunities for that in a minute. And then we can do some of that reframing. What am I seeing, and bring that sort of lens of curiosity. What unmet needs are happening here? And then as best we can work to calm the patient or the client's sort of physiological stress response first. So remember, they're most likely in survival brain, at least a little bit at that point. So we want to shift them back to learning brain before we try sort of any cognitive interventions or giving of information, because what I can share in all my years of working with traumatized clients is that telling somebody to calm down has never once actually helped them calm down. Trying to engage that learning brain when someone's dysregulated has really failed me every time. And I know that I'm becoming reactive if I'm sort of saying, you need to calm down before we, move on. So instead, it's offering some grounding strategies, some regulation strategies that may support that physiological state, and then we can get to the cognitive engagement. Okay, and some of that this has to happen over time. It doesn't work perfectly every time, but I'm a big believer in sort of seed planting, and we'll try it this time, and then we can try it again differently the next time if we need to. But some sort of quick ideas on how to engage. If we need to help them calm their stress response, to calm that dysregulation, breath is what's up there. And that's one that's obviously most accessible. For someone who may be in a shutdown sort of place, holding a cold pack, just offering them as something with a change in temperature, preferably cold, so they don't hurt themselves. That can help with re-regulation. Drinking water, so just simply offering a glass of water to somebody. Remember, our mouths dry up when we're in that stress response. So that can be an indicator to our parasympathetic nervous system that you are okay enough, you are safe enough. But sort of these body-based interventions can help, and intervening as soon as we sort of notice that someone's off their baseline can help kind of control the temperature in the room a bit. And then I'll be sharing some other options that help regulate ourselves, but also can be used for patients and clients too. So we just want to kind of bring that brain state awareness a little bit. Where is someone's brain at, so that we're not trying to engage we're being realistic. We're not asking the brain to do something that it really cannot do. Okay. So thinking about ourselves too, and the accumulated impact that we may experience that impacts our own sustainability, our own ability to stay involved in this work. I want to think about that now a little bit. And again, I'm going to give you a few exercises that hopefully are there for you. They're options for you, but you are also very welcome to take this into sort of your patient or your client's interactions as well, to help with and support their regulation. So for this section, I want us to think about our own stress response, how we know we're impacted, what are the barriers to addressing impact, and then I'll offer a few of those strategies, thinking about what we can do to sustain ourselves. All right. So first, I want to normalize impact. Okay. So this is a quote from she's a psychiatrist, I think. That the expectation that we can be immersed in suffering and loss daily and not be touched by it is as unrealistic as expecting to be able to walk through water without getting wet. When we are working with folks who have experienced trauma, we need to be thinking about not if we will be impacted, but when and how will I know? And then what can I do? I also want to think realistically what we can do about our sort of personal and professional resilience, and really also what's the responsibility of our organizations. So yes, when we experience sort of hearing difficult stories and challenging situations every single day, there will be impact to us personally. But if we don't have the opportunity to go to the bathroom, to eat lunch, to go outside, to see a variety of patients, all the resilience building exercises in the world can't change that sort of organizational stress that we're experiencing. We have to be clear on what's organizational impact and where we have our own agency to do things to metabolize our stress response and respond. Okay, so sometimes folks feel as if they feel a little hopeless, I think, in imagining how they're going to shift the experience. But I think the first step is, what's organizational impact and where do I have some opportunity to work on sort of my own metabolism of stress? All right. So step one, and again, I think we get to this at different points in our careers and our experiences, but recognizing impact for ourselves, first acknowledging that it's going to happen, and then recognizing it for ourselves. So personally, we can see it show up in a cognitive way, emotionally, behaviorally, spiritually, interpersonally, physically, and usually some combination of these. We can see it show up professionally in our job performance or our morale or with our interpersonal behavior with colleagues or behaviorally. And you'll notice there are a lot of similarities with the list of trauma presentations I showed earlier, and that's really by design. There's a lot of overlap, right? What vicarious trauma or impact looks like really closely mirrors primary trauma. But by noticing our own impacts, we can begin to address where we need support and help and where we need some extra resources, right? So if we, and I really offer this list as a starting point. It's sadly not exhaustive. It is evidence-based, but it's not exhaustive. It can be overwhelming, I think, to look at, but consider this simply a starting point to begin to understand we have reactions and we can name them. And then we can address them. But if we just sort of skip this phase, then we aren't sort of even properly addressing what's really going on for us, some of those foundational issues. Working in healthcare or public health or social services, we tend to have some pretty specific barriers to addressing our own needs, besides time, which is a universal barrier, I think. And we sort of get in the way. What are the things that get in the way of meeting our own needs? So providers and practitioners tend to engage in denial that it's even issues are present. And that's why we do start with simply naming them. But we have a hard time acknowledging our own humanity oftentimes, our capacity, our own capacity, or our levels of exhaustion. We are often caregivers, of our patients, maybe of our families. And so we have a hard time at times just naming that we have capacity limits ourselves. We often feel as if we need to present as healthy, that the cultures we work in encourage this as well, a fear of maybe looking less than. And many providers excel at being thorough and committed, really leaving no stone unturned. But those are who are the most dedicated to their work in that way kind of are at risk for being consumed by it. So bringing that awareness that what makes you a really good practitioner or provider, maybe the thing you have to sort of be guard against a little bit to make sure you're not sort of depleting yourself sort of beyond the ability to come back. We want people to be in this for the long haul. And so we need to address things sort of in the short haul so that we can stay in this. We also have a tendency to diagnose and treat ourselves. And I can also say from experience that we are not our own best clinicians. We are not our own best mental health personnel, that we really need outside support and help for that. And that can look different, again, for different people, but we have this tendency to, in our fields, to diagnose and treat ourselves. And then coping alone has really become a systemic issue. Folks have been obviously isolated during the pandemic, but prior to that, there were productivity expectations that have increased. We are often now seeing higher needs and higher utilization. We spend more time documenting perhaps, and so we have less interaction with colleagues. And we're not built to work in isolation, especially with high needs populations. We're really meant to work in collaboration and conjunction with others. And then we also have this survival mentality oftentimes that if I just get through the residency or a rotation or an internship or this period of limited staffing, then it will be okay. But this framework tends to be in our fields perpetuated throughout our entire careers. So we never get to that point of beyond. And so that can be sort of this survival mentality can persist for years and years. So these are sort of the barriers that we have to be thinking about addressing, and sort of the what gets in the way of taking care of myself and opportunities to metabolize sort of these stress responses that I'm having as well. So I want to think about that now. Where are our opportunities for our own regulation and the capacity to have the capacity to keep showing up? And I'm going to talk specifically about two areas, regulation or mini resilience strategies for when we maybe are feeling those moments of activation, and then some professional and organizational strategies. I'm not going to spend a lot of time talking about sort of bigger resilience or self-care strategies that are really important. Things like time in nature and exercise and sleeping well, those are really critical to our health and well-being. But we also know they're important, and we know we need to do them. And so I want to spend a little bit of time thinking about opportunities that get a little bit less attention, but that also can support us sort of throughout our days and help us metabolize a little bit each and every day. Okay. So I want to go back to our stress response framework, because we also experience our own stress response throughout the day, or many times a day. And if you remember, I mentioned that we can accumulate impact because of disruption with completing the stress cycle. So we never sort of get all the way down. We interrupt it sort of maybe around this release period. And so we're always living sort of just below the surface, or we're often living just below the surface. It's a really common phenomenon in our culture to not fully release. We have work demands. We have a culture of busyness. We have a culture of productivity. There's a lot to do, right? Whatever it is. So we end up living just below this heightened stress response, and we just sort of bubble and pop in up and down, okay? And so we become primed to enter it because we're not fully metabolizing our stress, right? We're living just below the surface, but we never fully get to that metabolization phase, okay? So I want to offer this opportunity to think about these mini strategies that are really short, brief strategies. They're intended just to get us a little bit further down the bell curve. They're not meant for that full metabolization. That really takes the things like consistent exercise, healthy eating, healthy sleep. Those are the things that support sort of full metabolization. But we can do these little minis throughout our day that just get us a little bit further down and away from sort of unpriming us a little bit, if you will. And we can use these as sort of to build muscle of resiliency and support getting to that rest and recovery phase a little bit more. And I sort of think about it like being hydrated, right? That hydration is important, But we're going to be better hydrated in our day if we take sips of water throughout the day versus trying to chug one big glass of water at the end of the day. That's not really effective in keeping us hydrated. And so these minis are sort of similar to that in that respect, that they're best utilized throughout our day. And also when we maybe pair them with an activity as a reminder that we're already doing. So every time we wash our hands, we can do one of these things, activities or interventions that I'll name in a moment. It helps us just support our own regulation. And then we also can draw on these in moments when we are starting to experience maybe some dysregulation in the face of a client or patient presentation as well. So these are minis again, and they're just some quick samples of things. There are plenty of other ways to do some of these grounding and coping exercises. But I think they should all start with an intentional pause or a stop. Pausing intentionally gives us a moment to get off autopilot. It creates a little bit of space between stimulus, sort of some of the behaviors and reactions we may be seeing, and response, what our own response is going to be. So if we notice someone else being activated or entering their stress response, this gives us just a little space to stop so that we can respond versus just react, okay? And then after an event, if we do have a stressful experience, it can also help with the discharge and metabolization of some of those stress hormones, and we sort of getting rid of some of that cortisol and adrenaline that's sort of living within us. We want to sort of get those out and discharge some of those so that we have room for the sort of happy hormones and neurotransmitters like oxytocin and dopamine, serotonin, those things. So practicing these mini exercises really supports regulation. Engaging our own parasympathetic nervous system so that we don't want to we don't want to end with the pause, but that's where we can start, right? So I think, Elaine, you were saying, pausing between patients so that you're not carrying one patient to the next, that's critical. But we also need to do, like you were saying, support some more actual metabolization of stress, okay? And so that's what these minis are kind of intended to do. So again, the pause is just offers our brains an opportunity to stay in learning brain and out of survival brain. And so it's simply pausing for a moment, taking a breath, observing quickly, what am I feeling right now? What are my choices? Practice one of these skills that I'll talk about in a second, and then you can proceed. So it just creates, again, a little bit of space. These will not solve the stressor. They won't solve the problem of what's causing stress. But again, it allows us to be in learning brain where we can have more capacity to deal or manage the stress itself, okay? And I encourage folks to print out a visual reminder. So print out a stop sign. You don't need my fancy sign with 2 P's if you don't want. Just a stop sign, a visual reminder, especially because it sort of engages our brain in a different way as a reminder of how important that pause is, okay? And then practice one of these. So breath is one of the most accessible ways to help regulate ourselves and our patients. And if you remember, when we enter in a stress response, our breath gets faster. And so by regulating breath, it's an indicator to our parasympathetic nervous system. It's that to come online and help us regulate. I want to caution, breath does not work for everybody. And so if you are someone or your patient is someone you're trying to teach this to, and breath is more triggering, don't push it. Just leave it aside, go on to something else. That's why I want to offer some options. So square breathing is one structured way to do some breath exercises. And that's simply by breathing in for 4 seconds, holding it for 4 seconds, breathing out for 4 seconds, and then holding for 4 seconds. And you just do this for 3 to 5, 10 breaths. And again, hopefully you'll see some deactivation and re-regulation. Another breath exercise is counting down from 10 with each breath. So you breathe in, and then you breathe out at the number 10, you breathe in, you breathe out the number 9, and you get down to 0. These should take 30 seconds to a minute. And again, several times a day, just like taking a sip of water. It just is a regulation on our own systems, okay? If breath is not an option, another thing we can do is physical grounding, some body-based intervention to bring awareness and again, re-regulation that help. So these help calm the brain. Drinking water, again, because our mouths dry up when we experience a stress response ourselves. So offering someone water or getting water ourselves is important. Finding acupressure points. So there's one in the webbing kind of your hand, between your thumb and your pointer finger. There are ones that you can around your temples that you can use. These are just, again, re-regulation opportunities. Many times when we are stressed, or our muscles clench up. And so by intentionally clenching and then releasing and doing that several times, that again is a sort of the notice to our bodies that they're safe enough. And so we can come out of that stress response a little bit more. But I'm sure many of us can relate to this feeling of ending the day with our, shoulders up by our ears. And that's a product sort of our bodies holding on to that stress from throughout the day. And then simply feeling your feet on the ground, so all 10 toes making contact with the earth, feeling supported by the ground, and just sort of breathing in that space if you want, or listening to sounds around you, closing your eyes, just feeling some support and contact with the ground. Those are body-based, again, physical grounding opportunities that, again, allow that brain to be told you're safe enough, you're good in this moment. And then the last one I'll offer is called Name It to Tame It. And this is about naming emotions. So this can help calm the amygdala too, that nervous system. So it will increase sort of prefrontal cortex activity. It sort of strengthens the communication between the limbic system and the prefrontal to say sort of like, whoop, you're good, you're okay. You are not this emotion. And so when we can sort of several times, maybe throughout our day, just name what we're feeling in this moment, it becomes less powerful and we can, again, respond in the moment versus reacting. So it promotes that healthy communication. And it also lets our brains and bodies know that we are not our current state of being all the time, right? We're not static, that we move throughout emotional states throughout the day. And so, and this sort of promotes that idea that we aren't just angry, or we aren't just sad. We are also happy sometimes. And so it builds that awareness that we're constantly in a state of flux and our emotions aren't static. This can be a helpful one to teach as well, I think, especially to some folks who struggle with emotion regulation when they are calm and regulated, to practice this, to utilize this practice of not feeling as if you are your emotions, but that in recognition that we are constantly in a state of flux. So I'm going to end on sort of these last few opportunities, thinking about professional and organizational support. I want to start and highlight with this idea of peer support and cultivating community, because community and connection can be sort of some of our most important resources to promote and support professional resilience. Social baseline theory tells us that our brains expect access to others, that those connections, those social resources, they get constructed as bioenergetic resources. So they're like fuel to our brain, like oxygen or glucose. That's what runs our brains, right? And so these social resources, they're really necessary to brain function. And so what we know is that by having someone with us when we're doing something difficult, the brain perceives that it actually takes less effort to do that. So if we can have a difficult conversation with someone else in the room with us, our brain constructs that as actually taking less effort and that it's a little bit easier. On the other hand, if the brain perceives like loneliness or isolation, then it outputs more energy. It takes more output. It deploys more energy to cope, which then depletes our energy and our resources, right? So that we feel more depleted by some of these challenging events or conversations. There was a really interesting study that showed that a hill appeared steeper if you were standing at the bottom of it by yourself. And it was more manageable if you were standing at the bottom of it with another person. So we're really wired for connection. So having these opportunities is critical. And it can be informal connection, sort of those water cooler moments we used to have where we can connect with colleagues without scheduling a Zoom meeting. But where we're simply sort of sharing time and space and swapping sort of stories and life events, and those informal connections are really important. But we also critically need formal structures to support learning, sharing, debriefing, processing information, processing challenging clients or cases. And this can be through things like ethics, compassion rounds, which Elaine and I both have experience with, or peer support programs, things like that, where there are these more formal opportunities for connection because these collegial connections are really critical. We need access to resources and appropriate resources to do our job. So lots of places put in, wellness experiences that folks could have, or many places have EAPs, or they have mental health treatment, but we need to be able to actually access those. And sometimes that's a piece that has been forgotten. And that's an organizational issue, that not only are these resources in place, but can we actually access those resources and be able to do our job better? Certainly training and development. We all need professional and continued professional development, so we have the skills to do our job, especially when we're seeing higher utilization and higher needs or changing client or patient dynamics. So we need to be able to understand what these new environments are, what this new landscape looks like. And then we need opportunities to recognize and acknowledge successes, not just pay attention in our own lives to the deficits, but also what's going well, what's working. And these can be formal or informal. And then I think, sort of to bookend, the other most important piece for me is that we need these opportunities to stay connected to our why. Why did we go into this? And why do we stay? Okay. And maybe more importantly, why do we stay? I've been doing work like this for almost 10 years. And every time I come back to this question for myself, I notice some sort of profound reconnection with the why. And even though jobs have shifted over the years, there's still a reason that this field matters, that the patients matter, that the clients matter, that the care we are giving matters. And so reconnecting to that why can help us sustain us and keep us in this work, I think, for longer. So I'm going to end there. And I know you've got some good stuff that you're going to be hearing from some other colleagues of ours in this work. So I'm going to turn it back over to Elaine.
Great, thanks so much. What a wonderful presentation, really appreciate that. And as Melissa mentioned, there'll be opportunities to really talk about this in more depth when we break out into the breakout sessions. But first, we're going to hear briefly just a sort of initial presentation, and again, they'll be facilitating one of the breakout sessions that will follow. We're going to hear briefly from Terry LaRocque and Sherry Breyer about the really cool program over in New Hampshire at Dartmouth called Moms in Recovery. So I am going to read their bios and to introduce them. So Terry LaRocque, MSW LICSW, is the clinical director for the Moms in Recovery program at Dartmouth Hitchcock. Social worker career experiences have included Boston Children's Hospital, Community Mental Health, Children's Hospital at Dartmouth, and work with the Behavioral Intervention Team in the Department of Psychiatry at Dartmouth Hitchcock Medical Center. Sherry has worked for the last 6 years at the Moms in Recovery program, where she enjoys integrating her interests in women's mental health, maternal child health, and addiction treatment. She completed undergraduate degrees in psychology and women's studies at the University of Vermont and holds a master's in social work from Boston University. Sherry Breyer is the recovery coach, CRSW, at the Moms in Recovery program at Dartmouth Hitchcock, where she provides peer support, recovery services, and advocacy to pregnant and parenting women. She's a member of the interdisciplinary pediatric and OB teams at Dartmouth Hitchcock Medical Center, where she works with women and families with substance misuse disorders. In her inpatient and outpatient role, she provides individualized advocacy, support, and referrals to community recovery resources. As a person in long-term recovery herself, she often accompanies individuals to medical appointments, recovery meetings, court hearings, and treatment. Sherry is a certified CCAR recovery coach and ethics trainer, leading many trainings in the Upper Valley. She's certified to supervise recovery coaches and CRSWs and has been an integral part of mentoring and teaching medical providers and caregivers throughout New Hampshire. She's appeared in documentaries and speaks at public forums on behalf of herself and people with substance misuse disorder. She's inspired to speak out and uses her own personal story of addiction to help reduce stigma and bring a voice to those who have been silenced. Her experiences in recovery are proof that people can change. That's the perfect transition. So I'll pass it to Terry and Sherry.
Thanks, Elaine. Thanks you. And Melissa, that was fantastic. That was really a great talk. So thank you so much for that. Sherry and I are just really want to tell you in about 15 minutes, a little bit about a program that we work in at Dartmouth Health. It's called the Moms in Recovery program. It's an integrated addiction treatment program for pregnant and parenting women. It's been in existence for about 8 years. And it started actually 8 years ago because women who were seeking OB, women who were pregnant were not, and had the disease of addiction, were really struggling with getting their prenatal care. And so the thought was that we would bring our medication assistance MOUD to and OB together in one clinical setting in an addiction treatment program. And the thought initially was that the women would come for about during their pregnancy and stay for about 6 weeks postpartum, and then they would sort of go on with their lives after that and go back someplace else. And we have women who have actually been with us for 8 years. We've had about 250 women go through the program. We currently have about 85 active patients now. And this is just a picture of our clinic space. We're off-site from the medical campus. We're in an old mill building, we have a little bit of we have challenges with some of the old mill building, but it's a great setting. And you can just picture this courtyard full of women with strollers and toddlers running around, and it's quite an active place. The next slide, please. Sherry, do you want to talk a little bit about this?
Sure. So this is a flyer that we have that sort of explains our program. The woman and the baby on the front are actually one of our earlier patients. And since the mother has had another child, and this little baby is now in kindergarten this year, mom is working full time now. She's been in a successful recovery as long as I've been at the program, and I've been here now for 6 years. So that's pretty amazing. Some of the things that we offer here are group, outpatient group, IOP, which is a step up from outpatient. It's an intensive outpatient program where the women who are newly in recovery or trying to get stopped, or maybe they've had a relapse, come into our program and spend 9 hours a week with us. We offer medication assisted treatment here at Moms in Recovery. We have Suboxone. We prescribe also injections of Vivitrol, which is another form of medication assisted treatment, and Sublocade. And those have been very successful. We've only had those two medications for the last couple of years, and the women that have chose to go on those from Suboxone are doing really well. We have many other things that are in our integrated program, and I think those will be in the next slide. If you'd like to switch to the next slide.
We should, I should also mention, I should have said before, we started as a program, you know, like I think a lot of programs did when sort of the opioid crisis was you know, sort of front and center. We had to change our brochure. It used to say, are you suffering from opioid use disorder? And now it says from substance use disorder. I would say that a good number of the women in our program have had a history of OUD, and that still continues. But by far, most of our women currently have struggled with polysubstance use disorder, significant number of increase in stimulant use disorder. So women coming here, it's not just about opiates. We have women who are struggling with methamphetamine, bath salts, cocaine, a lot of alcohol. So it's a little bit of a mix of everything. And we've had quite a changing landscape, especially I would say during and since the pandemic, when people just really increased in struggling. So we have this program is an integrated program with the Department of Psychiatry, the Department of OBGYN, and the Department of Pediatrics. And so at our organization, we had to build a whole new cost center because there hadn't been sort of a program that was, you know, shared between 3 departments like that. So we have behavioral health services on site. As Sherry said, women receive MOUD for SUD. They can look in various forms. We have perinatal psychiatry. So we have a psychiatrist on staff who works with the Department of Psychiatry and has a specialization in perinatal psychiatry. We offer group therapy. We have, I think, 9 different outpatient groups. 3 of them are virtual, and we have an intensive outpatient program also. We work really hard to provide not only trauma-informed, but trauma-responsive care here. Most of the women in our program have diagnoses of PTSD with histories of very complex trauma. We also have on site here, we have I'm making it sound probably more glamorous than it really is. It's really a small little clinic space. We have one treatment room where women do get prenatal care and women's health care. So they're coming in for contraception and things like that. We work closely with our infectious disease department, and we've been able to offer Hep C care on site as well. We have a primary care provider, family medicine provider who is able to provide pediatric care for the children when they come here. We have a collaboration with 2 different dental practices also. And something that I would add to this slide that we forgot to stick on here, we have a fairly new grant where we have an attorney on staff twice a week with a medical legal partnership. So she is someone who is here through New Hampshire Legal Aid to work with women around some of their civil cases that they have going on. And that's just been really fantastic. I should also mention that we're right on the border between Vermont and New Hampshire. So we have about 35 to 40% of our population is coming in from Vermont, and the rest are coming in from New Hampshire. Sherry, do you want to talk a little bit about the supportive services that we have here?
Sure. Some of the supportive services, or the supportive services that we provide here as well. We have a case management, like community resource specialist is what we call her, or in other places, it might be a community health worker, might be the title. And she helps with applying for state Medicaid services, getting people set up to take insurance rides to our program if they don't have a way to get here otherwise. Helps with housing applications, any types of social determinants of health. She's a really great resource and been a wonderful addition to our team. We also have peer support, and that's my role. And I'm here to really just advocate for the women, help with any needs that they might have, go to the lab with them to get blood drawn. That's a very difficult thing for people in recovery to do. Oftentimes it's very triggering. I go to court hearings with them, either if it's like a child custody thing, or state involvement, or even if it's a legal issue that they're working through. I'll go and support them through that. Many times a lot of their things they're going through, I've been through them as well. So it's a connection that I can make and help them, and they feel really supported by that. We also have a playtime coordinator here. So we have a room where the kids can come with their moms, and they stay with her and volunteers that come to our program, and they can be safe and looked after while their moms are in group, or if there's, having individual counseling, or even here to see our community health worker type person. And we have a donation closet. So moms bring in gently used items, and they share them, put them in the closet. Maybe they might take something that's in there that will fit their baby now. We have, sometimes donations of adult clothing. So if moms are going back to work, or if they need maternity clothing, a lot of times we have things like that. That's been a really great resource. And we also have a food shelf here. So whenever they come, they can fill out like a shopping list, and we give them bags of food, and we have a diaper bank, so we get them diapers when they come too.
Next slide, I guess. So this is just a slide about integrated treatment. What I guess I would also like to say about the program that's important to know, sort of in thinking about difficult conversations, because we have lots of difficult conversations all day long, every day. Women are coming into our program because they're seeking treatment. And they're seeking treatment either for internal reasons because they are, very, of course, eager to get stopped and to really enjoy a life of recovery. And many times they're coming in because they're being told they have to be here. So probation and parole, child protection, their family members, their partners, somebody's, really is sort of pushing them through the door to our program. And so having all of the services and everything on site, we try to be one-stop shopping, make it as easy for them as possible. And I think that that's been something that's been really helpful. I would say, I think Sherry, you and I've talked about this. So many women come through the door really hesitant, really not sure, really scared, really anxious, really nervous. And the environment itself is just really welcoming, and women are very welcoming of each other. So even though they may not have thought it was really their idea to want to be here, most of the time they stay. And I think, like I mentioned, we have women who've been with us for like the entire 8 years. So that's really great. So, so really the idea of integrated treatment is really, addressing the full range of a woman's need. I never realized this, but you can't actually get Medicaid transportation to a food shelf or to, a consignment shop to get, to get clothing, or, to your legal appointment, or to your recovery services, or to your case manager. And so a good number of our patients access transportation through Medicaid. The fact that they can come, and they have children with them, and they have car seats and strollers and an array of everything that we travel when we have our kids with us. So being able to come to one place and have everything under one roof as much as possible has really, for us, defined integrated treatment. The next slide. Sherry, do you want to talk about this?
Sure. So this is some of the things that come up for us when we're having and engaging in difficult conversations, and these things seem to help a lot. We try to have open-ended questions, always leave an opening for them to be able to share what they would like to share with us. So like, tell me what you want to accomplish during our conversation today. Tell me what your concerns are. What things would you like to address? What things do you want to change? Could you tell me what we can work on together to achieve what you want for your life and that of your family, in treatment and outside of treatment? Tell me what you're wanting for yourself, like right now, what brought you here? What do you want to get out of this? And lastly, tell me what is important for us to talk about today that will help me appreciate what your circumstances are and to learn about you, your abilities, your strengths, what you like, and what your hopes are for your life. And these seem to work really well. People really want to come in and talk to us. They, by the time they walk through our doors, they've been through a gamut of things, and we always try to make it as welcoming and encouraging as possible. Do you want to add anything, Terry?
Just in that, what Melissa mentioned, and that is really sort of seeing this as an opportunity to tell us what they need. You mentioned sort of the SDOH screen that we do, that our resource specialist does. And so, we started off screening everyone as soon as they came in. We were doing their evals and their assessments and giving them the SDOH, social determinants of health screen too. And we realized our SDOH data, was really garbage. It was really not good at all. And because our patients were coming through the door, and they were, of course, very hesitant to tell us how bad things really were and what their resource insecurities really looked like. So when they were filling out their SDOH screens, we were getting, incorrect data. No, they didn't have any legal problems. No, they didn't have any medical concerns. No, they didn't have, any resource insecurities. And it was only after we got to know them and to really engage with them and really develop a relationship, and where they were able to really trust us for all of the reasons that Melissa outlined so well. It took time in relationship building and carefully asked questions and giving them the space and time to tell us in their own time really what was going on about the intimate partner violence, about the significant resource insecurities. We had patients living in tents, living in cars. We had no idea. We had no idea sometimes when they came through the door, because it just wasn't something they were comfortable in telling us. The stakes are really high for the patients in our program who who are very anxious and very concerned about involvement around child protection. They have everything to lose and everything to gain. I think something that Sherry and I say a lot when we talk to people, it's, I think, a misconception about patients, about women with addiction who are parenting, is that, well, you know, if they just loved their children enough, they would just stop using. You know, they should just be able to stop. And that one of the things that I think I've learned from Sherry and that our women have taught all of us are that both are true at the same time. Women love their children very much, and they're excellent, wonderful mothers. And addiction is a very powerful disease. And so working together and identifying the strengths that Melissa talked about, and really honing in on things that are going well and trying to build those out is really the key to that relationship development that then results in them staying and remaining in treatment. I think that's the last slide that we have. Anything else, Sherry?
Nope, I'm just looking forward to the breakout room and having more discussion and talk about how other people handle difficult conversations within their practices.
Great.
Great, thank you so much. That was a great description and intro to our breakout sessions. So as we mentioned already, the breakouts will give an opportunity for people to ask questions and share experiential stories, along with hearing from those who have lived experience. So we're just asking folks in the next few minutes to think about a time that you worked with someone or were part of a situation that was challenging during a difficult conversation, and bring those thoughts and questions to your breakout session. Lorena is going to be putting the Zoom links in the chat for the breakouts. Attendees will be divided into groups by the first letter of their last name. So there will be one link for if your last name begins with A through L. And that session will be facilitated by Melissa, myself, and Amanda Thompson, who's a peer recovery support specialist. And then if your last name begins with M through Z, that session will be facilitated by Terry and Sherry. So that starts at 3:15, so it looks like you have a few moments to take a break, and then please join us in the Zoom room by your last name at 3:15. And thanks for your attention. We look forward to seeing you in a few minutes.
Hello, everyone. Thank you so much for being with us during the final half hour of our conference. I'm Dara Fruchter, Project Manager, Substance Exposed Infants and Maternal Use Prevention at the Maine Center for Disease Control and Prevention. It's an honor to be introducing Sherry Breyer and her daughter, Emily Duff, to all of you this afternoon. For those of you who didn't meet Sherry in this afternoon's earlier sessions, she is the recovery coach for Dartmouth-Hitchcock's Mom in Recovery program and is a member of the interdisciplinary pediatric and OB teams. Thank you so much for being with us during the final half hour of our conference. I'm Dara Fruchter, Project Manager, Substance Exposed and Maternal Use Prevention at the Maine Center for Disease Control and Prevention. For those of you who didn't meet Sherry in this afternoon's earlier session, she is the recovery coach for Dartmouth-Hitchcock's Mom in Recovery program and is a member of the interdisciplinary pediatric and OB. Hold on one second. Thank you so much for being with us during the final half hour of our conference.
Sorry about the technical difficulty. Just a second. People will be right with you.
Well, that was memorable. Sorry, I apologize. So let me just start off where I left off. For those of you who didn't meet Sherry in this afternoon's earlier session, she's the recovery coach for Dartmouth-Hitchcock's Moms in Recovery program and is a member of the interdisciplinary pediatric and OB teams at Dartmouth-Hitchcock Medical Center. Sherry provides peer peer support recovery services, individualized advocacy, and referrals to community recovery resources. As a person in long-term recovery herself, she accompanies individuals to medical appointments, recovery meetings, court hearings, and treatment. Sherry has appeared in documentaries and speaks at public forums on behalf of herself and people with substance use disorder. Emily is a wraparound coordinator for the Partners to Promote Permanency and Well-Being for Families and Children Affected by Substance Use Disorder. This is a 5-year grant-funded project through Dartmouth Health Medical Center and Dartmouth Hitchcock Research Center. She has been a recovery coach for the past 7 years. Emily's experience as a family member affected by parental substance use has made her passionate about helping anyone suffering from the disease of addiction. Sherry and Emily have shared their mother-daughter recovery story with many, many audiences and organizations. They are inspired to speak together to increase understanding about substance use disorder, reduce stigma, and offer hope, reminding others, many of whom feel silenced, that all things are possible. Welcome, Sherry and Emily.
Thanks, Dara. So I'm going to tell my story first, and Emily will tell hers after, and end with that. And I'll just start. I'll start where I always begin. So this is my story through the eyes of the mother and the addict. As you've already heard from earlier in the conference and Dara's introduction, my name is Sherry Breyer, and I'm the full-time recovery coach, peer support specialist at the Moms in Recovery program and in our OB and pediatric departments at Dartmouth Health here in Lebanon, New Hampshire. But what you haven't heard today yet is that I'm a woman living in long-term recovery from substance use disorder. But that is not what defines me. Above all else, I'm a daughter, a sister, an aunt, a friend, and most importantly, and my single most beloved and dearest to my heart titles are being a mother and a grandmother. And if you hear and remember only one thing from my story today, it's this: addiction is a disease of the brain, not the heart. I always start from the beginning, who I was before active addiction, where it took me, and where I am today. Addiction is not only a disease for the struggling person, it is also a disease of the family, and it touches each family member differently and independently. Just as the person with the actual disease and their journey is theirs to personally navigate, so does each family member that it touches. After I'm finished, you will hear my daughter's personal experience of living through addiction from a child's eyes. I think our stories, though each our own, are so important to hear. No two sets of eyes or hearts can share the same experiences and see or feel them in the same way. Both are equally as important to hear. I grew up in a small town of Hanover, New Hampshire, where Dartmouth College is located. And although many towns surround Hanover, it is unique in its own way and very different from the others. Hanover, as you can imagine, being home to an Ivy League college, is very upscale with many families of doctors, professors, and other white-collar professionals. We were not upper middle class, and we were not wealthy. Even at the age of 9, when I never knew there was a difference in the way people lived, I realized it very quickly when my family moved from the neighboring town, which was like moving to a foreign country. How different my lower middle class family was compared to the kids at my new school. From a very young age, I knew that my family was very different. Addiction and alcoholism have been prevalent on my paternal side of the family from as far back in our family tree as we've been able to find. In my father's immediate family, it affected his grandfather, his father, and 7 out of 8 children, including my father. In my immediate family, it has affected myself and another sibling, making it half of my parents' children. As for my own children, 2 of my 3 children suffer with substance abuse issues. It appears that we definitely have a genetic predisposition to addiction, where it sits in each of our systems, waiting for an opportunity to take hold and eventually control every aspect of the lives it has entered. It has wreaked havoc and devastation within my entire family, more than any other disease any one of us has developed. I have lost more family members from substance-related health problems than I can count on both hands. For myself, addiction came at a heavy price. It started in high school, the year my dad got sober. When life started to change and actually began to get the most stable it had ever been, I was resentful and rebelled. I was angry and I didn't know how to deal with any of it. In our family, things were just the way they were. We never talked about the drinking problem, and we never talked about when the drinking problem went away. I was a sensitive child and I wasn't able to stuff my feelings away, and I wasn't able to express them. So finding the escape that alcohol first and later drugs gave me from feelings I never was able to show became the most effective way for me to cope with them. Otherwise, they had nowhere else to go. High school was a great time for me. I was a cheerleader and I really excelled in my classes, but partying was also a big part of what we did. And my memories of drinking at high school parties were always fun, but I also remember when drinking, I did it to excess. I usually blacked out. I usually didn't remember exactly what had happened the night before. I began to start having female health problems in my late teens, and prescription pain medications entered my life as they were needed to treat multiple pain issues and for the purpose of years of multiple surgeries to deal with them. I had developed pelvic inflammatory disease at the age of 17 and was required to have several hospitalizations and exploratory surgeries. Later, it was discovered that I also had endometriosis. I tried to live as normal of a life in between the medical tests and procedures, falling in love with my high school sweetheart, getting married, and starting a family and a career in banking and accounting. Being told by my doctors and specialists that other than the prescribed pain medications, being pregnant seemed to be the only other time that I didn't experience extreme pain. I didn't mind that at all. Becoming a mother was the best thing that had ever happened to me. By the age of 24, I had 3 healthy, beautiful children, but I continued needing several surgeries to remove ovarian cysts and scar tissue. But by the time I was 29, I had my uterus, cervix, fallopian tubes, and ovaries removed, all of which were done in separate surgeries, due to trying to save what the doctors could each time because of my young age. In total, I have had approximately 20 abdominal surgeries in my 54 years of life, almost 1 a year for half my life. By my 30th birthday, I was a full-blown prescription drug addict. In looking back, it is impossible to decipher what medical interventions were completely necessary and what was purely addiction, and with that, my brain's altered perception of pain. I don't blame my medical providers for trying to treat my complex medical issues the best way they knew how. But unknowingly to myself and to them, they also became my drug dealers in the process, forever altering the relationship and trust for them and for myself. I will always have the flag of being a drug seeker and have to prove the need for medical care at the expense of almost costing me my life on several occasions, even with years of recovery behind me. My 20s, 30s, and early 40s were spent mostly in emergency rooms, hospital stays, having medical tests, procedures, and surgeries, away from my kids and family. I was for years at a time living in a drug-induced reality that destroyed every facet of my life. My marriage to my children's father collapsed when he was forced to choose between me and their safety. I was unable to care for them any longer and felt they were better off without me. I was unemployable and spent 16 years in the criminal justice system. I spent years in and out of incarcerations, psychiatric hospitalizations, rehabilitation programs, have had several drug overdoses, and surrounded myself with people who were unsafe and who didn't care if I lived or died. For a long time, I didn't care either. I lost my privilege to drive a car, and I racked up 6 felonies in less than 15 years. I remember times that I couldn't attend family events because I was no longer invited. People didn't trust anymore that I would be able to show up sober or even show up at all. I ruined my oldest daughter's graduation. My middle child would tell people she didn't even know me. And when my son was living back at home with me, The only time that he ever dared to go away on a trip with his friend and his friend's family, I ended up getting arrested and taken to jail. I was gone for over 3 months, which left my other children to care for him at that time. Since active addiction and the almost 9 years I've been in recovery this time around, I've had to completely rebuild my life and my relationships with all of my family, but especially with the ones damaged the most, with my children. I've had to realize and accept myself for what I've done, but more importantly, for who I am and what I'm worth. I've had to build new friendships because the old ones weren't really friendships and they're too dangerous anyway. None of this has been easy. As a woman and a mother, this should have never happened in the first place. The world judges me harshly, but no one harsher than me. The impact it has made on my life currently and in the future will always be challenging and potentially damaging for many opportunities I could have otherwise had or qualified for. I worry about what housing will look like for me as an elderly woman and having to explain why I have such an extensive criminal background. I will never escape my past for as long as I live. How many people with any other disease have to think about that? I constantly, in every area of my life, have to prove myself and my value and worth as a human being. I've also had some of the hardest and most difficult events of my life in the past few years. My son, who dabbled here and there with different substances, but mostly with prescription pills, was sold a pill that he thought was a Percocet 30, when in fact it was pure fentanyl. He overdosed and was on a ventilator and in a coma for 5 days during COVID, which meant that we weren't allowed to be with him at all. We had one Zoom call that whole time. My oldest daughter has recently had some life-threatening health issues, partially and possibly substance related, we don't know. And I've been able to stay sober through all of this. And I'm very proud of myself for that. Because of these things, I have more humility, transparency, and vulnerability than any other person I know. I also get to be the woman I always dreamed I could be. I get to be the mother my kids always deserve to have. And more importantly, my grandchildren get to have the Nana, who they will never know any other way than the way they've always known me. With them, I get to be the person that all of those years of pain and suffering cost me and everyone who lived them with me, but which also brought us all out of it stronger and much more resilient. Last weekend was my grandson's 4th birthday party, and it was a superhero-themed party. I got to celebrate with him and my other grandchildren and family dressed as a superhero, and so grateful that I'm still alive at a time in my life I never thought I'd even be here for. They get all the best parts of me now. After all, addiction is a disease of the brain, not the heart. And I'll pass it to Emily now.
Hi, good afternoon. I want to apologize. I'm more at the emotional side of the story. I'll try to keep it together and get through this as fast as possible, as I'm sure you've all had a long day. But thank you for allowing me this time. So my name is Emily Duff. Like it was said, I'm the wraparound coordinator for the P2P project here at Dartmouth. Outside of work, I'm a mother of 4, and I have 2 dogs, and I live in New London, New Hampshire. I did grow up in Lebanon, though, all around Lebanon. We moved around a lot as kids. What it was like for me living with my mom's addiction is I can remember my mom before her addiction. Very caring, very sweet, funny, always on the telephone. I remember my mom always having the phone. I remember holidays and family functionings. You know, there's good memories of very early on with my mother before her addiction took a hold of us. It wasn't until about the ages between 10 and 12 where her addiction really took over our home, where we would notice mom sleeping more. She wasn't really attending family functionings. She just really wasn't around like she used to be. Around that same time, I think between the ages of 10 and 12, without us without me and my siblings knowing what was going on. My mom went to rehab for the first time in Dover, and I remember our dad taking us down. I don't even know if she was there a day, maybe she was away from us. She ended up signing herself out and coming home that same day with us. So that's very foggy. So about a year and a half in between those same ages are kind of foggy for me. I don't remember much. I know we moved to Lebanon to our house where I say I grew up in. It was a lovely big house right on Mechanic Street, easy access to everything. I remember it was the fall of my 6th grade year. My dad setting us down, me and my siblings, and telling us that our mom is going away for a while to get help. My dad isn't very well educated. I don't think he didn't have great communication skills. So we were just left with, we're not going to see our mom for quite some time. And lo and behold, our mom never came back into our home. That was the end, the beginning and the end of their marriage, I believe. My father gave my mother a year to get sober without knowing addiction. You can't put a timeline on recovery. But when that year was up, my father had enough. He put it blatantly clear to us that he didn't want us waking up to find our mom dead, basically, because she was just so out of it all the time. It was scary. She would wake up with cigarettes, things burning, just stuff that you shouldn't really have to be exposed to at such a young age, or really any age of watching your parent struggle with addiction. But moving forward, a few years after that, so I'm mid-teen, my mom ended up in jail. I was more of the stubborn child. I'm the middle child, if that says anything. So I kind of distanced myself from my mother. I really put a lot of self-blame on myself, always wondering why I wasn't good enough to love. Why couldn't she just be happy loving us? What were we doing wrong? I really didn't understand addiction at that time. Didn't really care to either. Just, a stubborn teenager. So I visited her in jail for the first time, and wanting so bad to have your mom through those years, and meeting her sort of for the first time in jail and still not being able to hug her or touch her. It's a different, surreal life. It put in perspective how much addiction is and how much bigger this addiction was than I even thought it to be. Still those questions of why is this happening? Just unclear questions that I had. So fast forwarding a few years into my 20s, my mother's been in recovery for a little while. Things are going okay, but as time will tell, she ended up back up in jail. I'm on the phone with her talking, not telling her I'm taking a pregnancy test. Took the pregnancy test. I asked her if she wanted to hear some good news, and she said, yes, anything is better than this. I told her that she would be a grandmother. And almost in the same breath, I told her that if she was going to continue to live a life like this, that she would no longer have myself or my child in her life, because I was not going to raise my children to be exposed to the things that I was as a child. Those were some of the harshest words I didn't think I'd ever have to say to my mother. Not easy to think about saying those words, and I hope that nobody ever has to hear them. I couldn't imagine my daughter telling me that. That would cripple me. I don't know if my mother felt like it was her second chance. I don't know what it was, but becoming pregnant really changed our lives. I remember most of my pregnancy, my mother came out of, so she got released from jail. She was on house arrest. I lived with her basically my whole pregnancy. I'd bring her to work, bring her to places, be on her schedule. I really got to know my mom, and that's when we really started to bond and build our relationship. When I was 24 years old, was the first time I met my mother for who she is. I don't really know her, past that or before that. I went to NA meetings with her. I went to AA meetings. I heard her side of the story. I sat down. I really listened. And that's when I really began to evolve in the world of addiction. And I really wanted to start to start to help people. Because what we were given is such a beautiful gift, and the way our relationship blended out through everything is something that I wanted to share, and I want to help other people that there is hope at the end of the road. So having 9 years from that now, she's healthy. We're both working together. We do the same population. My kids can have their Nana. They can have the mom that I didn't. She talks boy talks with my girls, dress ups, birthday parties. I can't remember how many birthday parties. I wish I had my mom with me, and I'm just so glad that my kids get to have her as that mom, and I get to experience that through them. I get to watch and have her too. She's there for me. It's just different. But growing up and having that, I swore I'd never be like her. I didn't want to be like her. I wouldn't do drugs. For me, saying no to drugs wasn't hard because I put it in my head that I would never end up like my mother. So drugs to me were kind of a turn off. I did experience a little in high school, as every kid does, but it was easy for me to walk away because I always drilled it in my head that don't do that. You're going to have nothing. You'll end up like her. But now she is exactly who I want to be for myself and my kids. We built a whole new relationship outside of her addiction, outside of work. Addiction stole my mother from me, but recovery gave us all a second chance to become who we really want to be and help the population that we want to help. So my sappy story is all told. I appreciate all of you, and thank you for this time. I'm sorry that I got so emotional, but I hope you can understand. I hope you understood me. I hope it wasn't too foggy. But thank you for this time. You're on mute.
Oh, thank you. Thank you so much, Emily, and thank you so much, Sherry. And I do want to share with everyone that I've known Sherry for about 3 years. We're colleagues in an educational consortium focused on supporting children of the opioid epidemic. And she is a cherished colleague of mine. So this has been a real honor for me on a personal level. So that being said, I hope that everyone will just hang on for a few more moments. Marianne Haricol, our Director of Maternal and Child Health at the Maine CDC, will be giving closing remarks in just a few moments. Thank you very, very much.
Hello again. I get the pleasure of following that story up. Thank you so much, Emily and Sherry, for sharing your story with us. And Emily, don't you ever apologize for being emotional. That was, it was heart-wrenching to listen to. And I'm glad that the two of you are in the place that you're in now. And I wanted to go back and I had this whole thing written and you two just really threw me off a little bit. So, but we've had an amazing 2 days together of our different presentations, and I want to say a huge thank you to all of our presenters, for our folks who agreed to tell their story to us. You all just did an amazingly fabulous job, and I can't thank you enough for that. I hope that you all will take some time to sort of reflect on what we've learned, and I hope the experiences that were offered by our presenters, along with the many resources that were available in our virtual conference, will support the important work that you all do. And so I'm going to sort of end on, to help us improve any other trainings and other opportunities like this that we'll be offering in the future. Please be sure to take a minute and fill out the survey from AdCare, and they'll be sending that along to you guys through email within the next couple of days. So if we want to continue to have phenomenal conferences like this, it takes everybody. It takes everybody to give us ideas and feedback and what have you. And I just got a little message that there were 449 views on our virtual conference tables, and that is amazing. I hope that you guys took away as much information as possible And if you're looking for anything, you know where to find us, and we can certainly get you connected to things. So I do want to thank you all again, and we look forward to our continued partnership with everybody, and have a great evening. Thank you.